One, please start. So we are live.
Hello, good evening, and namaskar, everyone. It's a great honor and pleasure to welcome you all for this newer advances in oncology. And it's a pleasure to welcome and invite for setting a context for the day. We have Dr. Deepak Gupta, Additional Director, Medical Oncology for the prestigious Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. So once again, good evening. We carries the greetings from the Pink City, Jaipur. And now I invite Dr. Deepak Gupta, sir, to give his welcome speech, sir. Over to you, Dr. Deepak, sir, for your welcome note, and then we start the proceedings. Over to you, sir.
Thank you, Tarunji, for your warm welcome. And welcome to all of you, all the eminent faculties and audience, for sparing the time for today oncology update. So we'll have some exciting sessions on breast cancer, HER2 positive and TNBC. Then we have one session on NSCLCs and recurrent head and neck cancer, and one in ovarian cancer today. Additionally, Dr. Amit will be speaking the clinically meaningful updates from ESGO 2026, and then Dr. Ankit will brainstorm about the evolving treatment paradigms of endometrial cancer. I hope we all will learn something new today, and that will be helpful for our clinical practice too. So over to you, Tarunji, for starting the session.
Thank you so much, Dr. Deepak Gupta, sir, for these kind words. Now we'll be starting the session, and then I have a great pleasure to welcome and invite Dr. Ananya Parikh, ma'am. Ma'am, good evening to you. Ma'am is a consultant medical oncologist at Renova Hospital, Jaipur, and Madam is going to speak on reimagining myeloma, the BCMA bispecific era. So once again, very good evening, doctor, and over to you. You have 15 minutes for your presentations. Over to you, ma'am, please.
Okay, good evening. I'll just share my slide, right? So, good evening, everyone. First of all, I would like to thank Dr. Deepak Gupta, sir, for giving me this opportunity. And I would like to thank Pfizer for providing the slides and sponsoring the session. So the topic of today's discussion would be Elduxio, a BCMA-directed bispecific immunotherapy for adult patients with relapsed or refractory multiple myeloma. So Elduxio is indicated as monotherapy for the treatment of adult patients with relapsed and refractory multiple myeloma who have received at least 4 prior therapies, including an immunomodulatory agent, a proteasome inhibitor, an anti-CD38 antibody, and have demonstrated disease progression on the last therapy. So the presentation objectives are first to examine the unmet needs for the patients with relapsed or refractory multiple myeloma who are triple class exposed, who present longer term follow-up data demonstrating the efficacy and safety of Elduxio in a range of patients, and to discuss the key considerations for Elduxio dosing and administrations. So historically, there are poor outcomes associated in the patients with refractory or relapsed multiple myeloma, and there is a need for therapies that improve the deep and durable responses in such patients. So there was a study which was locomotion study, which did a median follow-up of 11.1 months and found that in patients with the relapsed refractory multiple myeloma, the response rates of standard of care therapies was 29.8 overall response rate, and the median PFS was of just 4.6 months, and the median OS was of 12.4 months. So there are poor outcomes in patients with triple class exposed multiple myeloma, and it demonstrates a need for improved treatments in this class of heavily pretreated patients. So Elduxio is a BCMA-directed bispecific antibody that can enhance the tumor-specific immune responses in the preclinical studies. So it binds to BCMA on plasma cells, plasmablast, and myeloma cells, and to CD3 on the T cells, which leads to activation of T cells and cytolysis of the BCMA expressing cells. And these activated T cells then causes pro-inflammatory cytokine release, resulting in myeloma cell lysis. So we'll be discussing the MAGNETISM-3 study, which is a phase 2 study in a range of patients with relapsed and refractory multiple myeloma. So it is an open-label, single-arm, non-randomized, multi-center phase 2 study of Elduxio monotherapy in RR multiple myeloma. So the inclusion criteria included patient age more than equal to 18 years, refractory to at least one immunomodulatory agent, one proteasome inhibitor, and one anti-CD38 monoclonal antibody, ECOG performance status of less than equal to 2, estimated creatinine clearance of more than 30 ml per minute, platelet count of more than equal to 2.5 lakhs, and ANC of more than equal to 1000. So excluded the patients with prior treatment with BCMA-directed bispecific antibodies. The total number of patients were 187. The step-up dosing schedule was used, in which it was administered 12 milligrams subcutaneously on day 1, 32 milligrams subcutaneously on day 4. Then in the following doses, 76 milligrams subcutaneously weekly from week 2 to through week 24, and thereafter every once in 2 weeks of 28-day cycle. So the primary endpoint was overall response rate. The selected secondary endpoints were complete remission rate, time to response, duration of response, MRD negativity rate, PFS, OS, and safety data. So efficacy was based on the overall response rate and duration of response in patients who received more than equal to 4 prior lines of therapies. So it delivered a deep response with nearly 67% probability of maintaining response at 2 years. The objective response rate was of 61%, in which 37.4% of the patients achieved CR. VGPR was seen in 18.7% of the patients, and partial response was seen in 4.9% of the patients. With duration of response, at the median 24 months, 87% of the patients with CR maintained response, and 66.9% of the patients with OR maintained some responses. So it showed median PFS of 17.2 months and median OS of just over 2 years. So at 18 months, the median PFS was of 17.2 months, and at 18 months, 90.6% of the patients, there was a probability of not progressing at 2 years if the patients achieved CR. And we can see in the Kaplan-Meier survival curve that the curves are well separated even at the end of 36 months. So the durability of response after longer follow-up, we have seen that in this study at 30 months for the efficacy population, the duration of response rate was 52.3% among responding patients, and outcomes for the full intention to treat population, which included the subset of 97 patients who received more than equal to 4 prior line of therapy. So at 30 months evaluation, 79% of the patients showed probability of maintaining a response at 30 months. So the response times, the median time to response in the MAGNETISM-3 study was 1.2 months, and it shows that it delivered rapid responses, and median time to achieve CR or better was 6.5 months in the patients who showed responses. The MRD negativity rate among patients who achieved more than equal to CR was, so overall 33 patients were evaluable for MRD assessment, and amongst them 19 of the patients achieved MRD negativity. To see the incidence and the management of adverse reaction, so most common adverse reactions were reported in 100% of the patients, with 87 patients experiencing grade 3 or 4 events. So of any grade, it was 100%, and the most common adverse events were hematological. So among any grade, the most common was anemia and neutropenia, which occurred in 60% of the patients, and of grade or 3, it was also hematological, the most common, and which was neutropenia followed by anemia. So amongst non-hematological, CRS was the most common side effect, which was seen in the 71% of the patients, but in grade 3 or 4, none of the patients had grade 3 or 4 CRS, and followed by diarrhea, fatigue, decreased appetite, pyrexia, COVID-19 related side effects, as this study was carried out in the COVID era. So treatment emergent adverse events were reported in 100% of the patients, with 87% experiencing grade 3 or 4. 55 patients, that is 44% patients, died on study. 4 deaths were deemed as treatment related because the study happened in COVID-19 era. More patients died because of the infection related deaths, and only 4 deaths were deemed treatment related by investigator. So neutropenia and hypogamma globulinemia was observed in this study. 45% of the patients experienced any grade of neutropenia, and 44% experienced grade 3 or 4. And 16.4% of the patients experienced hypogamma globulinemia, and amongst them 2.7% experienced grade 3 or 4. So 28.5% of the patients, these adverse events led to dose reduction, and it led to dose interruptions in 77% of the patients. And the most common side effect which led to dose interruption was infections, and most commonly it was COVID-19 related, and successful rechallenge occurred in 93.5% of these patients. So hematological side effects were most commonly neutropenia, and successful rechallenge occurred in 95% of the patients. So the most common infections were respiratory, coinciding with the ongoing COVID-19 pandemic during the study time, and grade 5 event was observed in 7.3% of the patients, and 71% observed overall infections. 51% had grade 1 or 2. So it is the dosing schedule of Elduxio. It is administered once weekly and then once every 2 weeks after week 25 in responding patients. So the pre-treatment medications were administered 1 hour prior to the first 3 doses. It is acetaminophen 650 mg oral, diphenhydramine or equivalent 25 mg oral, and dexamethasone 20 mg IV or oral. So on day 1, 12 mg subcutaneously dose was administered. It is a step-up dosing schedule to reduce or minimize the CRS and ICANS side effects. Then a minimum of 2 days gap should be maintained. Then on day 4, 32 mg was administered subcutaneously. And then 76 mg was administered subcutaneously on day 8 in week 2nd. So a minimum of 3 days gap should be administered, but should be maintained between the step-up doses 2 and the first treatment dose. So due to the risk of CRS, patient should be hospitalized for 48 hours after the administration of first step-up dose and 24 hours after the administration of the second step-up dose. 98% of the CRS events occurred within the first 3 doses. So then after week 2, it is administered every weekly till week 24 in the dose of 76 mg, and a minimum of 6 days gap should be maintained. And after week 24, in the patients who were responding, that is who achieved at least equal to or more than PR, then every 2 weeks it is administered in the dose of 76 mg to reduce the side effects. So these are the prevention and mitigation strategies for infections, neutropenia, and hypogammaglobulinemia. So before starting, patient should be monitored, baseline CVC should be obtained, prophylactic antimicrobials and antiviral should be administered, updated vaccinations are recommended, which should be killed vaccination, and within 4 weeks, live vaccination is not recommended till last 4 weeks after the last treatment. So antivirals and anti-PJP prophylaxis should be administered throughout the treatment. So during the treatment, it should be withheld based on the infection severity. CBC should be monitored periodically, and patients who are presenting with neutropenia should be monitored for the signs of infection. And in case of infection occurrence, the institutional guidelines should be followed. Immunoglobulins level should be monitored during the treatment, and treatment with subcutaneous immunoglobulin or IVIG should be considered if IgG level falls below 400, and patients should be treated according to the local institutional guidelines. And according to International Myeloma Working Group, immunoglobulin replacement therapy should be administered for any patients with IgG levels less than 400 milligram per deciliter. So prophylactic agents were administered in which antivirals were either acyclovir, valcyclovir, valganciclovir, or famciclovir. Antifungals were amongst fluconazole, posaconazole, or itraconazole, which was received by 11% of the patients. Antibacterials were levoflox or ciplox, which was received by 6%, and anti-PJP were received by 50% of the patients, amongst sulfamethoxazole or trimethoprim or atovaquone, dapsone, or pentamidine. So aldoxiotherapy can be delayed to manage the treatment-related side effects. So if the ANC is less than 500, we should wait till it is more than 500. Febrile neutropenia should be, the treatment should be withheld until ANC is more than 1000. Hemoglobin less than 8, the treatment should be withheld, and platelets, the treatment should be withheld until platelet count is more than equal to 2.5 lakh. In any grade 3 or 4 side effects, it should withhold, the treatment should be withheld until recovery to grade 1 or less to the baseline. So these are the recommendations to again restarting the Alduxio after the delayed treatment. So if the step-up dose was only 12 mg and the treatment was withheld, if the duration is less than equal to 12 weeks, then 32 mg should be recommended for restarting the therapy. If the gap is more than 14 days, then again a step-up dose from dose 1 should be started, that is 12 mg. If the treatment was withheld at step-up dose 2, that is 32 mg, and the duration is less than 14 days, then the treatment should be resumed at 76 mg. If the treatment withheld for more than 2 weeks but less than 4 weeks, then the treatment should be restarted from 32 mg. And if the gap is of more than 4 weeks, then the step 1 dosing schedule should be started, that is from 12 mg. And after any full treatment, that is the dose is at 76 mg. If it is less than equal to 6 weeks, then it should be resumed at the same dose. And if it is more than 6 weeks to less than 12 weeks, the treatment should be resumed at one step lesser, that is 32 mg. And if the gap is more than 12 weeks, the treatment should be resumed at first step up dose, that is 12 mg. So this is the step up dosing schedule which we have already discussed. So the incidence of CRS and ICANS with the first dose and the second dose, that is step up dosing, is the most common, that is 43% and 90% respectively. And if we see the further side effects of CRS, it is reduced to 7% and further to 1.6%. And the incidence of ICAN is further less, that is initially it is 2.7%, which is reduced to 0.5, and which is reduced to from week 2 onwards, it is just reduced to 0.5%, and no side effect of ICAN has been seen from the further week 2 dosing. So CRS and ICANS, in the majority of the events, these occurs within the first 3 doses at the median duration of 2 days. And the associated symptoms included fever, hypotension, and hypoxia. The supportive care included tocilizumab, siltuximab, and corticosteroids. In the ICANS, it occurred in 4.9% of the patients with the median onset of 2.5 days and the median duration of 2 days. The most frequent symptoms were depressed level of consciousness and grade 1-2 ICE scores. So supportive care included the same: corticosteroids, tocilizumab, siltuximab, levetiracetam, and anakinra. So the incidence management and mitigation strategies for infection, neutropenia, and
Dr.
hypogammaglobulinemia.
Ananya, ma'am, sorry to interrupt, but you have another 1 minute to conclude with your
I
findings.
think it is the last slide, yes. So it is according to the institutional guidelines. And so to conclude, the Elduxio demonstrated durable responses in survival after 22 months of follow-up. The overall response rate is of 61%, and the majority of the patients achieved CR. Median PFS is of 17.2 months, and fixed dose schedule, which we have discussed in detail. So it is available off the shelf, ready to use, rapid subcutaneous injection, and fixed dose with no weight-based calculation, and it will be available in India from the next month. Thank you.
So thank you, Dr. Ananya, for finishing in time, and thank you for such an eloquent presentations. You are being opening batsman, so thank you so very much. Now, Dr. Deepak, sir, any question for ma'am, or can we go to the next session?
No, you can go ahead.
Go ahead. Okay, fine. So thank you so much. Now we are moving to the next session, and this is again interesting session on the breast cancer. Again, we have a pleasure to request Dr. Ananya ma'am if she can do a needful for the talk. The topic is redefining treatment outcomes with immunotherapy in early triple negative breast cancer. And this is a sponsored talk by MSD. So thank you so much, ma'am, for considering our request. We request you to present your slides for this session
My
as well.
screen is visible, or do I have to share it again?
Ma'am, you need to share your slides again, please. Yeah.
Tech team, kindly stop recording.
I think my slides are visible.
Absolutely, doctor. Slides are visible and we can hear you well. Over to you for your
I
presentation,
would like
please.
to again thank Dr. Deepak Gupta sir and MSD for this opportunity. So today we will be discussing redefining the treatment outcomes with immunotherapy in early triple negative breast
for the treatment of HR plus HER2 low or HR plus HER2 ultra low MBC. Over to you, sir.
First of all, I would like to thanks Deepak sir for giving me this opportunity. Uh, Thanks, Pooja, for accommodating my last minute delay. So, coming to the topic of today, the NHER2 and HER2 low, just going to Pooja, can you share the slide? So, as we all know that NHER2 is probably the next molecule in the HER2 space, which probably surpassed trastuzumab in using. So, this is my prediction if how the data is coming up. But the one more interesting thing which this molecular showed us that even if the conventional HER2 is not positive, means HER2 IHC is less than 3 plus, the drug is still working. So we will dive through that how we can use that enumerator thing because from the trastuzumab era, we used to see that if it has HER2 3 plus, that is trastuzumab or anti-HER2 targeted or else it should be HER2 2 plus or fish positive. So here we are discussing something different. So we'll see the newer definition of how HER2 low, ultra low is there and how to sail through this thing. Next slide. So coming to the overview, we will introduce the background, unmet need in hormone positive, HER2 negative metastatic breast cancer. How does NR2 works? Destiny breast 06 design, DB6 efficacy, safety, HR related QOL, AE management, nausea, vomiting, pneumonitis. This probably now we are getting more well versed with, and we are coming to a conclusion that it is not that much worrisome, and the drug is efficacious. Yes, different side effect profile, but we can manage things. And then how to use this as per the summary and what those guidelines recommend. Next slide. Next slide. So this is the distribution of HER2 tumors. So conventional HER2 is only 13 to 20%. But if you see HER2 negative, TNBC is around 15 to 20%. I assume that everybody will have same outlook that Indian patients are more tend to be TNBC like 20 to 25%. And then comes the major chunk of the disease that HER2 positive, hormone positive, and HER2 negative. In HER2 negative, there is almost 10 to 15% patients are which have no staining for HER2. Around 10 to 15% are definitely not for any treatment. Then comes around 20 to 25% patient in this hormone positive subgroup, which is ultra low, means there is a minimal membrane staining. Around 20 to 25% patient does do this. Around 60% odd patient are HR positive, HER2 low by IHC positive, or IHC2 and FISH negative. So this is the subgroup, around 60% patient, which we are dealing with. Next slide. So coming to the how we do it. So obviously more than 10% uh, good membrane staining is IFC3. If membrane staining weak to moderate, but the cells are more than 10%, it is IFC2. If H is negative, it is percentage IFC2 means negative. If there is more than 10%, then incomplete membrane staining means membrane is fragmentally stained, then it is IFC1. Then IFC0 means stained incomplete membrane staining of less than 10% still. If it is absent, then probably it is IFC0. So around 60 to 65% patient fall in IFC2 plus which negative and IFC1 plus. Next slide. Next slide. So coming to what is unmet need. So definitely in hormone positive space, CDK4 inhibitor does do important role. Means we do have the data that ET plus CDK4 inhibitor in first line metastatic setting, almost 4 years without 50% of patients will not require chemo. Having said that, around 70% patients will only respond for 1 year or more, 1 year or more, but 30% patients will be having a disease which is difficult to treat because these patients are difficult to treat with chemo. Second line hormone therapy are difficult to give. Like if you have a second line ET plus targeted therapy, the PFS is 5.5 months only. ET monotherapy, it is around 3 months. If you give chemotherapy, it is around 6 to 7 months. But if you give third line TDXT, it is around 10.1 months. So the current standard of care are difficult to use in such chemo refractory patient. So there is a need for more efficacious targeted therapy, either in the treatment part. Next slide. So how does TDXD work? So basically, it's a monoclonal antibody which has highly potent topoisomerase inhibitor payload with 8:1 combination, which is a terapeptide-based cleavable linker bound to the trastuzumab. And once you give the drug, it bounds to the HER2 receptor. There will be uh, internalization of the molecule, there will be cleavage of the linker, and the drugs will be released, dopamine will be released in the cells, and that will lead to the other side cells, which will lead to bystander effect. That's why HER2 low tumor will also have some sort of effect with this drug. Next slide. So coming to the DB606 background study. So this is a study designed. It was an open label randomized multicentric phase 3 study. Hormone positive metastatic breast cancer who were HER2 low or HER2 ultra low. Chemotherapy naive in the metastatic breast setting means they were never not able to receive the chemotherapy in the metastatic setting. Prior more than 2 lines of hormone therapy plus venous targeted therapy or 1 line for metastatic breast cancer and progression within less than 6 months of starting first line ET plus ET4 inhibitor, which is the most difficult area to treat, or recurrence within less than 24 months of starting adjuvant DT. So more or less, endocrine resistant patients were randomized to 1:1 ratio, around 700 patients of low and 153 patients of ultra low. 800 odd patients were divided into 1:1 ratio to TDXD 5.4 mg per kg every 3 weekly versus the treatment of physician choice chemotherapy, which capacitor is the most common use, around 60%. Nab-paclitaxel and paclitaxel were rest of the therapy. The primary endpoint was PFS. Key secondary endpoint was PFS for in ITT, OS in HER2 low, and OS in intention to treat. Next slide. So if you can see that HER2 low and intention to treat patient and HER2 ultra low. So the baseline characteristic was similar. Only the HER2 low patients were lesser, around 150 versus the other. And majority patient did had the uh, almost half of the patients were white. Maximum patients were from the European origin. Maximum patients were of PS1 and 2. Next slide. Coming to the IFC of HER2 expression, which is more important. So in HER2 low, majority patients were IFC 1 plus, around two-thirds, and one-third patients were IFC 2 plus, which was FISH negative. Almost all the patients were both ER/PR positive, 60%. 40% patients were only hormone positive, ER positive, and very few patients were PR positive. Primary endocrine resistance was seen in around 30% of the patient, means patient progressed within 6 months of therapy. Stage 4 disease and diagnosis were around 30% of the patients, means they were never received any chemotherapy in their treatment paradigm. Bone only disease was less. Visceral disease was more. Around 90% patient had visceral disease. Liver metastasis was the most predominant site of the disease. Or around 10% of the patient, 7 to 10% patient were having brain mets, which was not symptomatic. And number of the disease sites were almost three in each of the subgroup. So these are heavy disease burden patients which were having more visceral disease. Next slide. This is what we see, and if you see that majority patients were 2 or more line in hormone therapy, almost 67%, two-thirds of the patient. So previous ET plus CDK4 inhibitor was almost 90% in both the arms. Fulvestrant were given in 20 odd percent of the patient, and ET with targeted therapy other than CDK4 inhibitor were only 30%. So a fair balance was seen in both the subgroup. Next slide. Coming to the efficacy, so if you see that PFS by BICR was 8.1 months in the physician choice versus 13.2 months in the TDXD arm, a delta of 5.5 months, and the hazard ratio of 0.62 is 38% this reduction, which was statistically significant. Next slide. Next slide. Coming to the overall survival, if we see in HER2 low, the patient had at 1 year, there was delta of 6%, and the graphs started separating at around 3 to 4 months, with the in 1 year OS of 81% in the chemotherapy arm versus 87.6% in the TDXD arm. Hazard ratio was 8.83, and if you see for the intention of treat, the delta was maintained and hazard ratio was improved. Around 17% decrease in the chances of death at 1 year. Next slide. So this is the forest plot, and if you can see that all the all the subgroup favored the TDXD arm. Only patient received nab-paclitaxel were on the middle, but probably the patient number was less. Even the patient with liver metastasis, heavy nodal burden disease, patient who had more line of therapy, all favored the TDXD arm. Next slide. So this is the PFS and OS in HER2 ultra-low as per BICR. So if you can see chemotherapy, the median PFS was 8.3 versus 13.2. The OS data was around 6% at 1 year with a hazard ratio of 0.75. Next slide. So this is the waterfall curve of both TDXD and chemotherapy. We can see that more patients responded in the TDXD arm with around overall response rate of 56% versus the standard 30 to 40% single agent chemotherapy responses, which you usually see in the breast cancer. 2% patients did had the complete response rate, and the clinical benefit was derived in almost 75% of patients in the TDXD arm. Next slide. This is PFS time of as per the proportion or early or progression on the ET plus CDK4 inhibitor. So we can see that the maximum benefit which was deriving was the chemotherapy resistant arm. Is the patient who progressed within less than 6 months. They fare better with a delta of 7.5 months. Although the benefit was maintained in all the three sub-arms, less than 6 months, 6 to 12 months, and more than 12 months. So the more resistant patient to the endocrine therapy, probably the chances of getting response is better. Next slide. So PFS2 was also better, 14.7 months versus 20.3 months in intention to treat population. And it was also seen in all the subgroup, less than 6 months, 6 to 12 months, and more than 12 months. Next slide. So if you see the disease, but if you compare the patient with disease burden, patient who had less than 3 local or metastatic site at baseline had a delta of 6.9 months versus patient who had a higher dozen. They did benefited, but the delta was lesser, 4.2 months. So benefit was there, but as the disease burden increases, the benefit was slightly lesser. Next slide. Coming to the safety profile of DB06. So means although it is a ADCC, but the side effect profile usually mimic to the chemotherapy. So there were treatment-related side effect almost 96% patient versus 90%, and the treatment discussion from countries was slightly higher, 14% versus 9.4%. Dose interruption was also higher. Still, having this, the patient who were having grade 4 or more side effects were lesser. So pneumonitis is a concern with TBHG. Around 5.3% patient had pneumonitis. And most common dose reduction was seen for TDXG is nausea in 4.5%. Next slide. So this is the exposure adjusted incidence of rate because TDXG was given for longer duration chemo. You can give for 6 cycle or maybe 9 cycle maximum. So if you can see that the permanent discontinuation rate was slightly higher, but the serious adverse event rate was almost similar, and more than 3 grade adverse event was 40 versus 30%. Next slide. Coming to the side effect of grade 2 or more, that was similar in both the study arm, except fatigue and pneumonitis were more in the TDXG arm. Nausea is a concern with the TDHD. So, because since it is a highly metagenic drug, so it was 70% versus 23%. Next slide. And coming to the pneumonitis, which is probably the most worrisome side effect, which we all medical oncologists should keep in mind. And it was more in definitely TDHD, but grade 3 or more were less. So if we can screen the patient properly, the probable serious pneumonitis are rare. And LV dysfunction, since anti-HER2 target is there, so LV dysfunction is seen in TDXD also. And cardiac failure rate, although this trial we have not seen, but that is also a thing which we should manage. Next slide. So this is regarding the quality of life. So quality of life was better and maintained in comparison to chemotherapy. Next slide. So coming to the conclusion that TDXG demonstrated a statistically significant and clinically meaningful PFS versus the conventional chemotherapy in hormone positive HER2 low metastatic breast cancer in earlier line of treatment than DB04. Results in HER2 ultra low were consistent with HER2 low. Confirmed overall was 57.3% versus 31.2%. No new safety signal were identified. Means similar side effect like ILD remains an important safety risk. So PFS in HER2 low was 13.2 months and HER2 low plus HER2 ultra low was 13.2 months. So DB06 established EDHD as an effective new treatment option for patients with hormone positive HER2 low and HER2 ultra low MBC following more than one line endocrine based therapy. Next slide. Coming to the two most common side effects which we see, like it is highly hematogenic, so we have to give 5-HT receptor antagonist, NK1 receptor antagonist, and dexamethasone for day 1. Day 2, it is not needed. Next slide. So this is the real world study suggests that probably 3-drug regimen is the best. So I usually give my patient combination of palazestrant or nitapatent uh, to avoid such side effects. Next slide. Coming to the worrisome side effect, which is pneumonitis. So we have to always ask the patient regarding cough, dyspnea, fever, new or worsening respiratory symptoms. So this is the thing which we have to see. Next slide. So how we should monitor this patient? We should auscultate the X-ray. We should talk about the chest symptoms, and we should screen the patient with
Uh,
HRCT.
Dr. Jitendra, sir, great presentation as always. Last 1 minute to conclude, sir.
Yeah, just to correct this. So if it is grade 1, definitely we can wait. If it is less than 28 days to recovery, we can continue with the same dose. If it is more than 28, probably we should reduce the dose. If it is grade 2 or 3, we have to include the pulmonologist into the picture. We cannot give the drug again. Next slide. So this is the screening portfolio. We have to monitor the saturation. Next slide. So regular assessment and patient education is key for early identification for ILD. Next slide. Summary, it is an effective drug when we compare with chemotherapy in HER2 low, 13.2 versus 8.1 months. The response rate is 56% versus 32%. Next slide. So if the patient, so this is the ISMO guidelines. So patient with hormone positive HER2 negative MBC, not a candidate for any EP plus minus targeted therapy. If there is no prior chemotherapy with MBC, if patient is HER2 low, we can give TDXT. If patient is not HER2 low, we can give chemotherapy. If there is a prior chemotherapy for MGC, HER2 low, we can give again TDXD. If patient doesn't have a HER2 low, we can give sacituzumab or maybe BRCA guided therapy. Next slide. So this is what NCCN suggests, that first line therapy in hormone positive, HER2 negative with visceral crisis or endocrine refractory, systemic therapy or BRCA1, BRCA2 mutation therapy. Next slide. So thank you for patient listening.
So thank you so much, Dr. Jitendra sir. Actually, this is absolutely recon time. So thank you so much for this wonderful presentation. Dr. Deepak sir, we have again a great pleasure to welcome and invite Dr. Amit sir. Good evening, Dr. Amit. It's a pleasure to have you with us today. And Dr. Amit is going to throw light on the learning from ESGO 2026. Everyone knows Dr. Amit, a senior consultant medical oncologist at the prestigious Apollo Multi-Specialty Hospitals at Calcutta. So, very good evening, everyone, and over to Dr. Amit. And sir, we request you to share your slides with us.
Yeah,
Thank you, Amit.
thank you, Deepak. Thank you, Horizon. And it's great pleasure to see you after such a long time.
Yeah.
So I don't just thank you for this meeting, but I thank you for all that happened there. At times when we were together, Siriska, cinemas, the 31st party where I was just done. So, it was great, when we were there together. And I hope we meet, more often than like this and we meet more.
Yeah, face-to-face meeting.
Yeah. So, when they said that this is by you, on the first instance, I said, okay, let me come and, see you there. So, ladies and gentlemen, today I have been given a task to present before you the ESGO, which happened in February, I think 26th to 28th at Copenhagen. And I will request organizer, to share the slides. So, disclaimer is that I did not make the slide, but I will give you my inputs, what I do think about those slides. And Deepak, I will catch you up once we are done there. So please share my slides. So see this, there were a couple of key learning points that we learned from European Society of Gynecological Oncological Conference of 2026. They gave good inputs about ovarian cancer, and what was better in say CS cervix, and what are the novel mechanism by which we can do target the drug resistance of the chemotherapy. So let's go to the next slide. Yeah, so next, go to the next one from this too. So, yeah, this is really important that they told us that, it was all about chemotherapy couple of years back, and the platinum resistant ovarian cancer, used to be very difficult disease to treat. And then they, gave us, something new, good trials to look beyond the chemotherapeutic drugs. And what do we have? So they presented in this important conference keynote B96 trial, which looked at, which proved that there is a good overall survival advantage of adding pembrolizumab in PDL1 positive platinum resistant recurrent ovarian cancer. And in endometrial cancer, they published that adding another immunotherapy, which is ETEJO, that was good for particularly for TMMR population, but then this was acceptable for PMMR population too. And in CA cervix, there was a groundbreaking, 11-month overall survival advantage for chemo-free combination, which I will discuss with you. And the Rosella was, to me, very eye-opening and very important, a trial that was published there, and which said that how you can overcome the drug resistance, chemotherapy drug resistant by a novel mechanism, which I am going to discuss shortly with all of you. So let's go to the next slide, please. Okay, so the first trial is, in the platinum resistant recurrent ovarian cancer. You all know that it's a bad subgroup, difficult to treat. You had only chemotherapeutic drugs, probably 3 or 4 types, which you will use before the patient will eventually succumb to the disease. And the median overall survival used to be classically less than 12 months. Apart from chemotherapy, you had bevacizumab in this setting, which little bit improved the survival. But now, immunotherapy has been firmly placed, and with a strong foot too by this Keynote B96 trial analysis. So this was a European Network Gynecological Oncological Trial Association with Keynote B96 trial, which was actually a randomized double-blind phase 3 study investigating pembro versus placebo plus weekly paclitaxel. Bevacizumab was left to the discretion of investigators whether to use or not use this in the platinum-resistant setting, and the responses were measured by RECIST 1.1. Yeah, move to the next slide, please, again. So what they found was very interesting. The median PFS was improved by approximately 2 months, and the hazard ratio favored adding pembrolizumab versus placebo, which was 0.74. Median OS was prolonged by approximately 3.6 months or 3.5 months, and again 25% reduction in the risk of death or progression. And not only that, the response rates were 10% better, favoring the pembrolizumab compared to placebo. So what this trial tells you that this is very short or brief discussion of this trial, and if you have any further question, I will be very happy to answer, or you can ask this question when the moderation happens. So this trial tells you that there is something new, a new kid has arrived on the block, that you use pembrolizumab, and addition of pembrolizumab compared to chemo plus minus bevacizumab improved not only PFS and OS and overall survival, overall response rate too. So this is really big, and this is a new agent which will be used frequently. Go to the next slide, please. Yeah, so Rosella, is one of the kind of the trial which you will hardly see in, when you study the clinical trials in detail. This looked into the role of relacorilant, which is actually a gonadotropin receptor antagonist. And you also must know, ladies and gentlemen, that this glucocorticoid receptors are often expressed in ovarian cancer, and they contribute to chemotherapeutic drugs being resistant when you use them because they inhibit apoptosis. And this trial, they use this drug intermittently to resensitize the tumor to the drug. So, in this trial, what they found, the key findings were that 30% reduction in the risk of progression or death with a hazard ratio of 0.07. There was a clinically meaningful extension of 4.1 months in median OS, and the subgroup which benefited most where the benefit occurred regardless where the PARP inhibitor or the bevacizumab was used in this kind of patient. So in this kind of setting where we know that there is only chemotherapy drug, now you have bevacizumab and also you do have pembrolizumab, but then you must find out something novel which will block the chemotherapeutic drugs resistance and will improve the survival. So this is a kind of trial which I was looking forward, and this has rightly come out at this meeting. Yeah, go to the next slide, please. So very important, very novel. Now, we do come across, a path-breaking trial on endometrial cancer, the use of frontline immunotherapy. So endometrial cancer incidence is rising globally, and what they found out in this R10 trial, they evaluated the role of itolizumab in combination with standard paclitaxel and carboplatin in frontline setting. The updated result of this trial confirmed that addition of itejo provided benefits in the this provided benefit in all comers also, but this provided most benefit in the DMMR subset. Yeah, little bit move up this slide. Yes. So in the DMMR population, you see the hazard ratio for PFS was 0.36 and for OS it was 0.049. And in PMR group, the benefit was modest, and in all comers also the benefit was modest. So maybe Atejo plus Paclicarbo may not be for all population, But for DMMR population, it is must. So you from tomorrow onwards, we all should check about DMMR status and other molecular targets which are expressed in uterine cancer, because even in early cancer, based on whether there is pole DMMR status P53, you will like to modify your treatment. Go ahead, go to the next slide, please. Now we move to cervical cancer. What is the innovation in the first line treatment? So standard treatment, you all know, for the recurrent and metastatic cervical cancer has been the platinum-based chemotherapy. However, toxicities and resistance do limit their long-term use. Now, so what this trial looked at, using Pembrolizumab, which is an immunotherapy, plus Femitinib, which is a oral TKI, which inhibits multiple pathways. And they showed that, the median OS was 34.4 months with IO plus TKI versus 23.4 months with chemotherapy. So, more than, say, 11, 12 months gained there. And absolute gain was 11 months, and median PFS was also, improved by approximately 3.5 months in this trial. And the hazard ratio favored that. This is interesting. So this tells you that probably, chemotherapy might be obliterated in future in the front line cervical cancer. So they will have, better OS, better PFS, lesser toxicities, or, you should not say lesser toxicity, but different kind of toxicities, which will be really manageable. Yeah, go to the next slide, please. Now, this is interesting slide, but then you are all aware of side effects of what happens when immunotherapy is there, or what happens when TKI is there, and what happens when none of them are there. So I don't want to emphasize a lot on this trial, lot on this slide. So toxicities will be very, very different from one or other agent, and you all must be aware how to deal with those toxicities. And if there are questions on toxicities, I will take them on. Move to the next. Probably this was the last one. Go to the. Yeah. No. So what was the key overall take away from this trial? So mandatory was that you do please check PDL1 and MMR testing, because they are non-negotiable, and you can decide about first line and second line treatment, ovarian cancer or uterine cancer based on them. IO plus chemo triplets are redefining survival expectation, as we discussed about this ART-10 trial. And, there will be, something like this Rosella, which is, to me, this was the defining or the evening making point for me, that, how do you target drug resistance because of chemotherapy, and you do block glucocorticoid receptor inhibitor, and then the survival might be better. And we should all look forward for the revival of chemotherapy by various means, and this was proved by Rosella that this is one of the way to do that. So this is it. Probably I should say thank you to all of you, and I'm done. If there are any questions, you can ask me, and if there's none, I will wait for you, and your panel discussion, and I will give my inputs at that point of time. So thank you, Deepak, thank you all others who were there, tonight, for listening to all of us.
Thank you, Amit. We'll talk to you later.
Sure, Baba.
Hello, Dr. Ankit.
Hello, sir. How are you?
I'm fine. How are you? Good.
I'm good, sir. I'm good. Thank you.
Tarun ji.
तरुण जी 8 बजे के हिसाब से वेट कर रहे हैं शायद.
Right.
Good evening, Dr. Ankit Agarwal.
Hi,
We
good
welcome
evening.
you. Dr. Ankit Agarwal is consultant medical oncologist, pediatric and adult, hermato, oncologist, GMCH, Udaipur. Now, sir, we'll start the panel discussion on management of endometrium cancers. The doctors in panel are Dr. Ankur Punia, Dr. Neha Rawat, Dr. Rahul Kumar Rai, Dr. Abhishek Charan. I welcome all the doctors.
Hi, good evening. Thank you, Deepak sir, for giving me this opportunity, and very glad to be here. So, is it should we start, Dr. Deepak sir?
Dr. Ankur Punia in the panel is Assistant Professor. He is in Department of Medical Oncology, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Dr. Rahul Kumar Roy, Medical Oncology, Jeevan Raksha Hospital, Bikaner. Dr. Abhishek Charan, Consultant, Medical Hemato-Oncologist, HCG Center, Cancer Center, Jaipur.
Hi, good
We
evening.
welcome.
So, should we start?
Sir, yes, over to you, please.
I'll just share the slides. Wait. Are my slides visible? Is it?
Yes, sir.
Yes, sir, it's visible.
Oh, okay. Okay. So, I welcome all my panelists. Do we have all the panelists here? Dr. Ankur? Oh, yes, I see Dr. Ankur. Dr. Neha Rawat? Do we have Dr. Neha Rawat with us?
Sir, I spoke to her. She said she's outside. She will join in between.
All right, all right. Dr. Rahul Rai? Do we have Dr. Rahul?
Sir, spoke to him as well. I think he has not joined yet.
And Dr. Abhishek Charan?
Yes, he has joined.
Okay. Dr. Deepak sir, should we start or should we wait for people to join? Can we wait for just 2 minutes?
Yeah,
Hi,
yeah,
Dr.
sure,
Ankur.
sure. Please.
I request doctors in panel, please switch on your camera. Sir, please start the session.
Okay, okay. Okay, so we've been given around 30 minutes for a panel discussion. Dr. Abhishek Charan, I'm not able to see Dr. Abhishek. Is he here?
Sir, I am here. Sir, I am here.
Hello, sir. Okay,
Hello.
we have two panelists. I think two more panelists are yet to join. We'll start the discussion with our two panelists who are already on the board. And probably once the other panelists join, we'll add them into the panel discussion. Yeah? Okay, so basically in the next 20-30 minutes, what we'll be discussing is the recent changes that have happened in the endometrial cancer. We've been trying to adapt to the recent changes that have happened in endometrial cancer, predominantly in the M0 setting and also in the M1 setting. We have few cases to discuss. I think we'll start with the case presentation. I'll prefer starting with a metastatic case, and then probably if the time permits, we'll shift on to the M0 case also. So here we have a case. We are a 65-year-old lady, hypertensive with dyslipidemia, hypothyroidism, complaints of postmenopausal bleeding for 3 months and shortness of breath. Talk performance status 1. Assessments done, found to have endometrial mass. The biopsy of endometrial mass suggestive of endometrioid adenocarcinoma grade 2. Metastatic on the CT scan, multiple lung, liver metastasis, and having a uterine and vaginal mass also. So the final diagnosis that was made was stage 4B, uterine cancer, endometrioid type, grade 2, proficient MMR, no specific molecular profile, ER negative. So this is what we have, the information that we have till now. So coming to the discussion, Dr. Ankur, the information that we have provided to you, is it a sufficient information for you to start on treatment for your patient? So we'll restrict our discussion to the best possible treatment for the patient, keeping the cost aside. Dr. Ankur.
Yeah, so we have the most of the information. Only thing I want to know about the TP53, which has not been mentioned, or P53, whether it's
Okay.
positive or negative, just to
All
give
right.
it some idea about the, because otherwise it's proficient NSMP ER negative. So these are the patients who do the one of the worst, more or less same like TP53, even if TP53 is negative. So these
Yeah.
patients are of the out of all the molecular markers, this tends to be one of the poorest prognostic markers for these patients. So
So routinely,
at least, I
are
mean,
we doing all for all of metastatic patients? Are we doing ER status as well as P53 cases status currently for all our patients? MMR, I
yes,
do understand. So for all the patients, ER and P53, is it?
yes, I'm doing for all patients because now we have that regarding an NSMP subgroup, that ER positive subgroup does better and ER negative group does worse. So I'm doing for all ER, PR, and because now NGS has also become quite cheap, we can do all the things in the NGS and just ER, PR extra is needed.
Okay, okay, agree. I think we do have good data to say that if a patient is affordable, definitely we should get all these testings done so that it helps us in prognosticating as well as in determining what is the best therapy for the patient. So, Dr. Abhishek, as per the information given, how would you like to treat the patient? Patient has MMR proficient status, advanced stage endometrioid type of endometrial cancer.
So if a patient is even proficient, I'll give first RT followed by chemo along with the IO, because in proficient also I think in Ruby trial dostarlimab has a good result. Though it will have better in deficient, but even in proficient it can be considered.
So basically, so if a patient is supposed to get immunotherapy, there a role of getting an MMR done? You know that for deficient MMR, we know that definitely immunotherapy has a very good effect when it is combined with chemotherapy. But even in proficient, we know that the
Yes,
data.
yes.
So do you still want to get an MMR done?
Yes, sir. Yes.
So does it help your treatment? Does it help to determine the treatment if your
No,
MMR?
it helps in at least in guiding whether the outcome will be better. I mean, prognosis and all that, and I mean the efficacy and plus proficient deficient, the IO role will be. I mean the efficacy and the result will be different from proficient to deficient. So I'll definitely get it done.
So, Dr. Ankur,
Dr. Ankit sir, sorry to bother. Can you make it as a full slideshow?
oh, I'm so sorry. Yes, yes, absolutely. Sorry. Yeah. So, Dr.
Absolutely.
Ankur, does your treatment plan change as per whether the patient has deficient MMR or proficient MMR?
So in proficient MMR, we don't know actually which subgroup actually benefits from immunotherapy. There is sort of a mixed data. Not everybody patients, the magnitude of benefit is not that much. Yes, some patient benefits, some doesn't benefit. For MMR deficient, we are sure that we have to give immunotherapy. For proficient, yes, we can try, but we have to, it gives us an option to explain to the patient that we might not get that much of a benefit which we see deficient. And there is a likelihood that immunotherapy will not work for these patients. There's a high likelihood of that. But still, because we have evidence that even for MMR deficient, immunotherapy works, we have to give the option.
Okay. So I think we'll again come to this question once we have the data from all the three trials: the Ruby, the Pembro trial, and the Durva trial, the DOE trial. I think we can again take up this question. So, Dr. Ankur, you said that P53 is very important for you to decide on the treatment, and it is of prognostic value. So, suppose this patient had a P53 mutated status, what are the treatment options you would have considered? Does that treatment, suppose you have planned immunotherapy with chemo, for suppose dostarlimab with chemo was planned initially, and the report comes as P53 mutated status, does that guide you that you want to change your treatment? MMR proficient, P53 mutated,
These
does
patients
that?
are again doing to get worse. The
Okay.
TP53 mutation patients are actually who benefit the least from immunotherapy. A very small subgroup actually benefits from P53. So these patients, basically are going to do the worst among all the endometrial patients. So we have in back in the mind that probably these patients we have to look for a closer follow-up, regular monitoring to look how the patient responds. Initial treatment might not change. I'm not that much in the favor of giving immunotherapy, adding immunotherapy with the plus minus benefit. So that's the thing.
Okay. So, Dr. Abhishek, does that P53 mutation status guides you to add on a PARP inhibitor?
No, sir, I'm not using it. But yes, the prognosis wise, what Ankur sir said, I agree with it. IO won't work much and all that. But we can add on later on, not in first time.
Okay. I think there was one meta-analysis that said that probably those patients who had a proficient state, and a P53 mutated stage, adding a PARP inhibitor with IO had a better benefit as compared to not giving anything, only chemo. So that was just a meta-analysis. It has not come into the guidelines, but probably P53 can help you in deciding whether a PARP inhibitor has to be added or not. The only question that remains is we don't have a long-term OS data for addition of a PARP inhibitor, and no validated predictive biomarker. So does that is will that be actually beneficial to a patient or not? We are not very sure. So I think the overall consensus I'll be agreeing with all is P53 mutated patients do very bad, and giving and the patient should be explained about the poor prognosis even with
Can I
IO.
add something here?
Sorry.
Can I add something?
Yes, please, Ankur, please.
So the TP53 mutations, which are usually common in endometrial, are because there is some data, preclinical data, that some TP53 mutations are sensitive to PARP inhibitors.
Yeah,
But actually, those mutations are slightly more common in the ovarian side. In endometrium, those mutations are not that much common.
absolutely,
Because
absolutely.
we are not looking at TP53. Eventually, we are going to look at not all TP53 mutations are sensitive, and in TP53 is a quite a complicated mutation. There are so many different kind of mutations and all. We don't see it. So that to extent, tells us which patients might be sensitive to PARP inhibitors.
Absolutely, I agree. Absolutely, Dr. Ankur. Okay, so we have three major trials that have led to the approval of immune checkpoint inhibitors in advanced endometrial cancer. The Ruby, that because of which the dostarlimab was approved in first line setting. NRG-GY018, we have pembrolizumab, and with the Duo-E, we have the Durva that was approved in the first line setting. So I would like to ask our panelists, do you have any criteria which helps you to decide what is the immunotherapy of choice for your patients? So we are talking about proficient MMR. For deficient MMR, we have very strong convincing data that immuno should be added for all the patients to with chemotherapy, and we know that the advantage is huge. So we'll not discuss about the deficient part. We'll discuss about the proficient MMR patients. We have three trials in front of us. Do you have any criteria, and do you have any points to determine how do you choose which regimen you want to use for your patient? Dr. Ankur, let us start with you.
So I try to give only immunotherapy, not a big fan, and I don't see that much of, I told you, PARP inhibitor again adds very small benefit that to in an SMP subgroup. So I don't add PARP inhibitor, just immunotherapy. I'm happy to give. I
Yeah.
don't have any particular choice. I'm happy to give either of the three immunotherapies.
Okay, so the difference that I was looking at was Ruby was the only trial that had looked at the OS. It was a predetermined primary endpoint that was looking at the OS. NRG and DOE primarily looked at the PFS. Is that a good enough point to give dostarlimab over Pembro or Durva?
So I think that's just a statistical how you design a trial. I don't think that it matters much because we look at the graphs and the results. The results are not that much of different. There is a slight difference between the population which they have taken, but I feel that overall doesn't make that much of a difference.
Okay. What about the PFS data. The OS data strongly says that Ruby had shown a OS significant advantage. The NRG and the DOE did not show a significant OS advantage, probably because the OS data is still immature. I think in the next 2 to 3 years, once we have the mature OS data, we'll be in a better position to decide what is the preferred choice of treatment for our patients when it comes to proficient MMR. But looking at the PFS data, it was very interesting to me looking at the PFS data. The PFS in the DOE trial, I'm sorry. Okay, so the PFS do we have other panelists? Have they joined? Dr. Neha, Dr. Rahul Rai? Okay, Dr. Abhishek, just one interesting feature that I was looking at the PFS data. When the PFS of Durva trial was compared with the placebo, the Durva with chemo versus the placebo with chemo, PFS was not very significant in the MMR proficient endometrial cancer type. Whereas in the Pembro arm, in the Pembro trial as well as in the dostarlimab trial, it was very significant even in the MMR proficient population. Does that mean anything? Do you
Yes, sir.
do?
Yes, sir. It influences with this is what I was mentioning previously. So in Ruby 2, if chemo plus IO in proficient MMR, still IO will have a role. And though PFS is not the end point we are, I mean, expecting we go for OS only in metastatic, but still it will influence our decision making. So, and you highlighted very good point that only Pembro plus Dosteri, even in Pembro Dosteri is having better outcome as compared to Pembro, but Duva is not showing as per optimal outcome at this. So it's an interesting fact.
Yeah, I think PFS was not the difference in PFS in the DOE was not very significant when the comparison was done as compared to what we saw in the Ruby 1 and the NRG, the Pembro trial. So that was very significant to see that um, uh, even with even with the almost similar population, slight differences, the PFS was very very significant in the Ruby and the NRG trial. Now, this I think these are the differences for all. We have one more table to look at the differences between all the trials. Coming to the Ruby Part 1 trial, the dostarlimab and the chemo arm, it showed a significant OS benefit in the overall population, wherein 75% of the population was MMRP. I think that was the similar data, similar population in the NRG as well as in the DOE trial also. The risk of death was reduced by 31%. I think taking OS as a primary endpoint, to me, it is still significant. But I think probably in the next 2 to 3 years, once the data gets matured for the DOE and the NRG trial, I think we'll be in a better position to decide on whether we are able to use, whether we have any pointers to determine which is the best regimen. Currently, to me, I think taking PFS as a marker, I think probably Dostarli and Pembro slightly scores over Durva. So these are the key study characteristics of all the three trials that we are discussing, the Ruby 1, NRG GY018 and the Duo E. Now, as you can see, OS was the primary endpoint in the Ruby 1, OS was the secondary endpoint in the other two trials. 3 years of Dostarli was given for the Ruby 1, whereas the other two trials, the immunotherapy for Pembro arm was given for 2 years, and for Durvalumab it was given until progression of the disease. Now, I think these are also the differences wherein the carcinosarcoma patients, which are considered as high risk categories, were included in the Ruby 1 and DOE trials, and it was not included in the Pembro trial. That was also, I think, one different point. Although the number of patients who were included who had carcinosarcoma were less than 10%, I think, but still, considering that they took high risk patients, probably if we have a patient of carcinosarcoma with these with stage 4 disease, we can go back to the trials and look at which were the populations who did the best. Now coming to addition of PARP inhibitors with ICI, Dr. Ankur, you said that you're not very fond of adding PARP inhibitors with ICI, but we do have preclinical models suggesting that when PARP inhibitors are added to ICI, probably they cause exposure of the neoantigens, and that can lead to enhanced efficacy of ICI. What do you have to say with that,
So
Dr. Ankur?
there are
So
some
you can
certain
also
studies,
discuss on
though
this.
we don't have any big study. Smaller studies in breast cancer have showed that the combination didn't show any drastic responses. Even in endometrium, we have to understand that MMR proficient is a very broad subgroup. It's TP53, NSMP. NSMP is like the extra TNBC. We don't know. It is the biggest subgroup. There are so many different classes. So
Yeah.
actually, a particular subgroup only benefits. We look at the trial also. Around 5 to 10% patient actually benefits from the duo. If you look at the PFS, around 10% more is it is. So not everybody, benefits from PARP inhibitor. Adding four drugs, giving more complicated therapy to the patients with benefit only a small subgroup. MMR deficient, definitely no benefit. So that's why I think we need more, molecular data to define the subgroup. When we get the molecular data, a little bit longer follow-up of the DuoE, they have a more molecular data available. We will actually know which patient subgroup actually benefits from adding, PARP inhibitor along with immunotherapy. I have tried it in multiple malignancies. I have not seen that much of a responses because there were preclinical data, as you told, that it enhances, but I'm still not convinced regarding that it's not for everyone.
Dr. Abhishek, your opinion on PARP inhibitors with ICI?
Sir, I think it is quite promising, but I haven't used myself yet, and it is evolving. What I feel as of now, so we can wait, and I'm not sure whether how much it will contribute on, but it's quite optimistic, and we can consider it. But I don't think at present.
Yeah, I think the data looks interesting, but I'll agree with my panelists. I'll agree with Dr. Arun and Dr. Abhishek. I think it's we are not ready to incorporate PARP inhibitors routinely into our practice when we consider treatment of metastatic endometrial cancer. The DuoE trial, I don't know, it was little bit complicated to me, honestly, because what happened? The Durva plus chemo with olaparib was compared to chemo alone, and the other arm again, Durva plus chemo was compared to chemo alone. We don't have a data to say that what was actually the benefit of adding olaparib. We don't know what how much olaparib contributed to the benefit. There was huge benefit in terms of progression-free survival in P53 mutated population. There was a good amount of benefit in those patients who had in terms of progression-free survival. But what was the benefit that was contributed by olaparib? We are not very sure. So I think I'll also agree with my panelists that we are not in a position to incorporate olaparib or other PARP inhibitors routinely into the clinical practice. Also considering we don't know what was the population of the patients who were HRD positive, who had homologous recombination deficient population in the trial. We were not very sure, although the number of patients who are HRD in endometrial cancer are close to 10%, not more than that. But still, once we have that data, I think we'll be in a better position to decide on whether PARP inhibitors are to be added or not. Again, Dr. Ankur pointed out a good discussion that adding PARP inhibitors adds to the toxicity. As you can see the graph in front of you, chemotherapy with olaparib, with durva, there were a lot of toxicities which were added, especially toxicity, addition of toxicity related to olaparib, hematological toxicity like anemia and other toxicity, especially fatigue. So when we don't have a very strong data of addition of PARP inhibitors and we do know that the toxicity profile increases, I think it's time to give PARP inhibitors some rest. And considering probably in the next few years we'll have data and which will help us in deciding about the PARP inhibitors. So we all know that ICI regimens have improved the outcomes for patients with MMR proficient endometrioid cancers. MMRP are highly heterogeneous with varying prognosis. ICI with chemo is, I think, we all have come to a conclusion that probably for all patients of MMRP, ICI with chemo is providing a good benefit, not so much so as compared to the deficient MMR population. Right, Dr. Ankur and Dr. Abhishek, I think ICI plus chemo should be used for all MMRP, but with some grain of salt. Dr. Ankur and Dr. Abhishek, your opinion on routinely using ICI with chemo for MMRP population?
Yeah, agree same because we have to explain that might not get that much benefit, but yes, still some people will definitely benefit. So we have to give options to all.
Yeah, so I think routinely we should give options to all, explain them that this is the situation, and I think let the patient decide whether he needs to take on whether he wants ICI or not. Uh, Choosing an ICI, I think it's still. Do you have any pointers to how do you want to choose? Suppose a patient has carcinosarcoma. Okay, we'll have one more case scenario in which we can discuss about carcinosarcoma. Adding PARP, our panelists are still not very convinced about the data. So I think I'll agree with that. OS data is still immature, adding to the toxicity, adding PARP, currently not into the routine practice. ICI plus TK also, we know that it has not provided any significant benefit. We'll not go into the details of that. One more case, I think we'll just discuss about this case also. I think that is because of the histology that has come into picture. Uterine carcinosarcoma stage 4, p53 mutated again. So this lady had if I had was 75 years of age, multiple comorbidities, postmenopausal bleeding, diagnosed to have uterine carcinosarcoma stage 4, p53 mutated, proficient MMR expression. Dr. Ankur and Dr. Abhishek, your discussion on this patient population. Is there any treatment that you want to change as compared to the previous patient? Is there anything that you want to consider?
So
Is there
patient actually has one more, poor prognostic. He has a patient has a carcinosarcoma. He has. So again, but the overall treatment, I would think, will not that much change. The only point which might be there that certain trials didn't have carcinosarcoma, certain trials have. But these patients behave more or like how patient endometrial with TP53 mutation carcinosarcoma patients. So I don't think that makes much of a difference. What we have discussed more or less that will apply. And I will be happy to use either of the immunotherapies.
So I think the Ruby trial included patients with carcinosarcoma. DOE included patients
Yeah.
with carcinosarcoma. Pembro, we don't have patients of carcinosarcoma. I think this is a good enough data to say that probably Ruby or DOE can be considered. And DOE did not have a PFS benefit for MMRP population. So I think probably DOE Ruby scores over DOE, and depends how your patient is wants dostarlimab. Affordable, definitely I think we should go for dostarli. What do you say, Dr. Abhishek?
Yes, sir, I agree with you. The dostarlimab will, I mean, definitely can be considered in such a aggressive histology. Whether it will work or not in Indian scenario, we haven't seen much about it.
So
But
prognosis
definitely,
remains poor. Prognosis definitely remains poor. But if we look at the data, I think we are in a position to we can tell the patient that this is the data Ruby has.
yeah,
Dostarlimab was the drug that was used, and
Doctor.
probably we can provide
I
dostarlimab.
agree with you, sir. I agree. We
Although
can
prognosis will still remain poor for this patient. There was a PFS subgroup analysis in the Ruby trial. Now, Dr. Ankur and Dr. Abhishek, one more interesting point that I wanted to discuss. What about routinely using pole mutation as a guide to your treatment plan in M1 endometrial cancer? I'm not talking about M0. What about M1 disease? Are you doing pole mutations for your patients?
For patient who can afford it, so and the data shows as you give any treatment, these patients will do well.
So
Whether
basically,
you give immunotherapy or not, because initially there was a hype that immunotherapy will work, but actually it has been
exactly.
shown that patients do well
Very good.
irrespective of any kind of treatment,
So
even in early.
if your patient has pole mutation, will you give only chemotherapy to your patient?
I'll be happy to just give only immunotherapy, only chemotherapy.
Oh, sorry, only chemotherapy. Dr. Abhishek, your take
Yes, sir.
on pole
Yes,
mutation?
sir. Yes, sir. I feel the same that the outcome will be better. Chemo will suffice, and no other, and the prognosis will be better in the such.
I think pole mutation patients are very good prognostic patients. Although we don't have that in the guidelines as of now, but probably in the future we will see that pole mutations being routinely done for all the patients, which definitely pole mutation is a prognostic marker, but probably it will also come into the guidelines as a predictive marker. Probably using only chemo should suffice for these patients who are pole mutated, even in M1 disease. I think that's a very interesting subgroup analysis that was done by the Ruby researchers. Okay, again, it was also shown in the Ruby trial, the subgroup analysis, that those patients who had TP53 mutation status also responded better with dostarlimab as compared to placebo, even when progression-free survival was considered. So probably that is one more a positive impact of dostarlimab uh, in this molecular subgroup, which are high risk. Again, I think we have discussed the addition of PARP inhibitors to immune checkpoint inhibitors in P53 subgroup. There was small meta-analysis that was not a small meta-analysis, that was a meta-analysis that said that probably P53, some people of P53 mutated endometrial cancers with proficient MMR might benefit with addition of PARP inhibitors, but with increased toxicity. I think we'll come to the end of our discussion. Probably M0. I don't think it's a very good. It's a good time to discuss. We have been using all the mutations for our adjuvant cancer patients. I wanted to basically discuss the differences between Ruby, DuoE, and the NRG trials. And do we have any pointers to decide on which is immunotherapy or immune checkpoint which you will use? So just the key takeaways from um, a panelist, Dr. Ankur, just key takeaways. If the category of a patient is this is the immuno that you will be probably using. We have just
So,
4 more minutes,
so
3 more minutes.
so what I want to do molecular testing for all patients. That should
Exactly.
be done. Just not to prognosticate, just for the indication. Regarding use of immunotherapy, as I told, I'm happy with either of the immunotherapies. PARP inhibitors, we need a longer follow-up. Whether the PARP inhibitor will truly make an impact, longer follow-up will tell us.
So are you convinced of about using durvalumab in proficient MMR patients?
Again, the benefit is small, but I'm happy to give, because as we look at the longer follow-up, the thing with immunotherapy is at the longer follow-up, we see more. Actually, we see the subgroup which benefits. If you look at the DuoE also, study, if you see at 12 months, there's not much of a difference, but at 18 months, the difference started to came
Yes.
slightly later, because might be of the different, patient population and design trial, but difference was there. So I am happy to give it.
Dr. Abhishek, your just key takeaways.
Yes,
2 minutes.
sir. Definitely, pole as a prognostic deficient MMR will have IO. Even in proficient, we can consider. And P53, whatever we do, PAP can be considered, but overall will have a poor prognosis.
Right, right. So I think molecular markers are to be done for everyone, not only MMR. I think P53 for prognostication and probably for later on predictive as a predictive marker. I think for all comers, I think if you want to choose, what I feel is probably Pembro and Dostarli, they stand at one gate. And for me, I think, I don't know, I'm not very convinced with the Duo E trial, considering the PFS benefit was very minimal in the proficient MMR patients. But I think for patients who are proficient MMR, I think for me, Dostarli and Pembro are at the single site, and they have provided a significant benefit. So I think I'll end from my side. Thank you for a wonderful panel discussion. I hope we did justice to the panel, and
Thank you, sir.
thank you,
Thank you.
everyone. Thank you.
Thank you, sir.
So thank you so much, Dr. Ankit sir, for such a brilliant presentations on the subject, and thanks to all the esteemed panelists for their valuable contribution. Now, moving forward, thank you, Dr. Deepak. I think this is the first time we are saying that the conference is going absolutely in time. So thank you so much for moderating too well. Now we are moving for our next speaker. and this is Dr. Pulkit Nag. So, Dr. Pulkit, good evening to you. I'm sure you're available, and you're going to throw some light on the PARP inhibitors in advanced ovarian cancer beyond HRD
Yeah.
status. So, Dr.
So
Pulkit,
good
sir,
evening
good
to everyone,
evening,
and
and we'll give you the stage, and you can share your slides, please.
sure, sure. So good evening, everyone, and thank you to Dr. Deepak Gupta, sir, for giving me the opportunity to discuss this presentation. And I'll just share my slides. Is it visible? Is it clearly visible?
Yes, sir, visible.
Okay, okay. So yeah, so I think we're going to discuss one of the most important topic, and I think it's PARP inhibitors in advanced ovarian cancer beyond the BRCA and HRD status. So let's discuss some important points. The session is being sponsored by GSK. So we all know that ovarian cancer has the highest mortality rate for the gynecological cancers and the eighth most common cause of cancer-related death in women globally. So second ovarian cancer, second most gynecological, and with a 70% mortality rate, the median age is around 55 years, with a 92% reported cases in stage 3 and stage 4. So we know that the first line use of PARP inhibitors maintenance therapy, that is post chemo, post debulking surgery, when there is a good partial response, has shifted the ovarian cancer treatment paradigm. So despite the advances in surgery, chemotherapy and biomarkers, around 70% of the patients will advance ovarian cancer relapse in the first 3 years in the absence of first line maintenance therapy. So we can clearly see in the diagram that when we do the debulking surgery, we reduce the tumor volume, we reduce the symptoms, and then comes the point of precision. So if we don't give the maintenance, there will be high chance of recurrence. And if we give the maintenance, then we can see the flat blue line. And this is what the power of maintenance PARP inhibitors. So what is the goal of maintenance therapy? Prolong benefit following surgery and chemo, induce a lasting remission or improve disease-free interval, manageable toxicity and minimal negative effects on quality of life. So I think this is a timeline, the data landscape and the evolution of first-line metastatic therapies that have been enhanced in the standard of care of patients. So from 2003, when the paclitaxel was been discovered, then 2018 we have solo trial olaparib, then we have Paula 1 and Prima trial, that is niraparib in 2019, then we have Athena mono trial rucaparib, Prime trial niraparib in 2022, then 24, and now we have Paula 1 final analysis, that is Ola plus Bev, Prima final analysis, Niraparib as first line metastatic. And so all these trials show that how we have moved from a single agent chemo drug from paclitaxel to the use of third generation PARP inhibitor, that is rucaparib. So I think this is the slide showing that progression-free survival benefit with the first-line PARP inhibitor maintenance therapy has been observed across different biomarker subgroup in the ovarian cancer. So we can see whether we talk about Prima trial in which we compared niraparib versus placebo, to Prime trial, to Solo 1, to Paula 1, and to Athena mono. I think in all these trials, the response was being maintained even in HRD, in homozygous recombinant proficient tumors. But the response is obviously much better seen in BRCA mutation tumors as well as HR deficient tumors. But also in HR proficient tumors with the discovery of Prima trial and rucaparib, the response was also positively seen in HR proficient tumors. So we have a consistent benefit across all the subgroup population. So if we talk about in ESMO 2024, the clinical practice guidelines for the use of PARP inhibitors as maintenance therapy in newly diagnosed ovarian cancer. So we do the BRCA testing, and then on the basis of BRCA testing, how do we decide our maintenance therapy? So if the patient is BRCA mutated and it has partial or complete response to first-line platinum-based chemo, then we can use olaparib, niraparib, or the combination of Ola plus Bev, that is Paula 1. Or if there is HR deficient or BRCA wild type and PR or CR to first line platinum, then we can use niraparib, Ola plus Bev, or rucaparib. Or if there is HR proficient or HR deficient unknown and if there is a PR or CR to platinum, then we can use single agent Bev, niraparib, or rucaparib. There is no role of olaparib in this. So all the major guidelines recommend PARP inhibitors in first line metastatic treatment and underlying working maintenance treatment selection based on various patient factors and characteristics. So if you have to decide which PARP inhibitor to be given to which patient, there are various factors to be considered. So if you look about what are those factors, we can see from disease point of view, we have disease characteristics. That is, what are the symptoms? What are the staging of disease? What is the molecular biomarker status, whether it's BRCA, wild or mutated? What is histology, low or high grade response to the drug? Or what is the outcome of surgery, whether there is residual disease left or not? For patient characteristics, we have overall treatment plan, comorbidities, patient preference, whether patient wants to go with IV drug or a oral therapy, quality of life, and the general performance status. With the drug properties, what is the ease of administration, the interaction, the safety, and efficacy. And with the accessibility, we have whether how much in our OPD we can go for a genetic breakout HRD testing, what are the approval and indication, and how is the financial burden to be bear by the patient. So I think all these four factors decide that which treatment to be chosen for the best in ovarian cancer patient. So now we'll just talk about what exactly PRIMA trial is. So it is a phase 3 randomized double-blind placebo-controlled trial of niraparib maintenance therapy in patient with newly diagnosed advanced ovarian cancer who have responded to first-line platinum-based chemo, and patient with a newly diagnosed advanced ovarian cancer at high risk for recurrence after response to platinum. It is randomized to niraparib versus placebo, and let's see what are the response for the patient. So, like if we look about the various other trials, as we have discussed, that the patient characteristic, the residual disease, the use, the response to the chemotherapy really matters the final OS and PFS benefit. So if we compare the other trials from Prima to Paula 1 to Prime to Atheno Mono and Solo 1, we can see that most of the stage 4 disease patients was quite included in Prima trial. And the colors are basically to indicate the proportion of high risk patient, in which the green represent the lowest proportion and the red represent the highest risk of the disease. So we can see that in which trial there are the maximum stage 4 disease. So we can see in the Prima trial, majority of the high risk patients were included, and this show the difference of disease characteristic as well as how it is related to the response to that drug. So with the Prima included patient with platinum response advanced ovarian cancer at high risk of recurrence. Initial treatment, around 2,000 of patients received prior neoadjuvant chemo, in which partial response was seen in 30% and around 70% has shown the complete response. The patient had to have either CA125 decreased by more than 90% during their frontline therapy, which is being stable for more than 7 days. And if we talk about the HRD status, so around 20 to 21% are homologous recombinant deficient and BRCA wild type, while rest of them are BRCA mutated or homologous recombinant deficient. So all these things influence the response seen in the first and subsequent lines. So here is the results. At 5 years, the niraparib reduces the risk of disease progression or death versus placebo in intention to treat population, as well as in HR deficient and HR proficient population. So I think the most discussed line in this is HR proficient. It has shown that niraparib in the view of Prima trial also work in HR proficient population. So as far as quality of life is concerned, the quality analysis C30 has shown that there was no any such significant side effects of niraparib as in view of tolerability, and so the quality of life was maintained in niraparib versus placebo. So the final overall survival analysis showed no difference between the treatment of intention to treat ITT, HRD, or HR proficient. So in the niraparib group, the median OS was 47 months for ITT, 72 months for HRD population, and around 37 months for HR proficient population, despite the high risk characteristic. So this is the important slide showing that a threefold higher and early post-progression PARP inhibitor used in patient randomized to placebo versus niraparib. So it has shown it that the gray is placebo and the blue is niraparib. It has been shown that if we use placebo first, then there are higher chances of using a further lines of therapy. Whether if we use niraparib as a maintenance, then there are lesser chances of progression and lesser chance of use of further lines of therapy. Yeah. So this is the long-term safety and it remains consistent with up to 7 years of follow-up. So the median treatment exposure was 11.3 and 8.3 months in niraparib and placebo arms. And the most common grade 3 adverse effects in niraparib was thrombocytopenia, anemia, and neutropenia. So there is a bone marrow suppression and a lower frequency of hematologic toxicity with initial starting dosing. MDS and AML rate with niraparib is around 2 to 3%, and no noticeable different contribution of treatment-related adverse effect to cause of death. The death rate in niraparib was around 2.5%, and the primary cause of death in both the arms is disease progression. So there is no major death occurring in view of side effect, and the reason for the death is the disease progression itself. Now, we have discussed by far the PRIMA trial. Now, what exactly is PRIME trial? So, PRIME is a phase 3 conducted at 29 hospitals in China, evaluating an initial starting dosing of niraparib in patient with newly diagnosed advanced ovarian cancer at very high risk for disease progression. So, around 28% of the patient had stage 4 disease, and approximately three-fourths of the patient had no residual disease after debulking surgery. So now I think that is the major difference between PRIMA and PRIME, that in PRIME trials, the stage 4 disease are lesser. In PRIME trials, the residual disease is less. So we have included the patient who have shown more CR to the chemotherapy. So that's why if you look at the progression-free survival with blinded independent central review, PFS was 16.5 months longer with niraparib than with placebo. So if you look at the separation of the curve is more than if we see in PRIMA trial. And the basic difference is that in PRIME trial, there are lesser of stage 4 disease and there is lesser of residual disease being seen. And I think that is the important part of disease characteristic we have discussed previously, that how does it influence the survival rate also. This is the forest plot showing results of analysis by biomarker status, and it is the results were consistent in all the population we have seen. Now, in the PRIME trial, the median PFS with niraparib were longer than in PRIMA, reflecting the differences in patient disease characteristics. That's what we were thinking, that in a PRIMA trial, the OS was PFS was lesser than placebo. The difference, if we compared with PRIME trial, and the reason is that there were lesser residual disease in PRIME trial, and there were lesser stage 4 patients included in the PRIME trial in comparison to the PRIMA trial. So this is the summary of treatment emerging adverse effects in PRIME trial. The median relative dose intensity was 100% for both niraparib and placebo. And in the niraparib group, around 6.7% of the patient discontinued treatment compared to 5.4% in the placebo group. So nothing of a major difference, and most of the side effects were still manageable. So the trial summary, that PRIME trial is niraparib initial starting dosing based on body weight and platelet count was effective and generally well tolerated in first line maintenance setting. The inclusion of patient with lower risk of disease progression at the baseline uh, compared with PRIMA result in sustained progression-free survival benefit over placebo regardless of baseline clinical characteristics, and the trial included Chinese patient with newly diagnosed advanced ovarian cancer. So in the median PFS, as we have seen that PFS was 3 times longer versus placebo, indicating the potential impact of disease characteristic on outcome. Now this we have discussed, the randomized phase 3 PRIMA trial, PRIME trial, how important is the role of niraparib in the first line maintenance setting, how niraparib is working both on BRCA mutated, HR deficient as well as HR proficient population. Now it's a real world data. We have AR1ZE. It also demonstrated significantly longer real world PFS in stage 3 niraparib treated patient without residual disease. So around 25.21 versus 10 is in concurrent with standard data. What about patient with R0? So a significant proportion of patient had no residual disease uh, after the surgery across PARP inhibitor in the clinical trial. Yes. Same is a significant proportion of patient had no residual disease across the PARP inhibitor in the trial. So data demonstrate the potential for first-line PARP inhibitor maintenance therapy in the settings of PCS0. Uh, so if we look that optimal debulking R0, R1, the response with the prime trial, we can clearly see the separation of the curve, and it is maintained both in Athena mono as well as in Paula 1 trial. So with in prime trial, it is 47 versus 30. In Athena mono, it is 25 versus 12. And in Paula 1, it was 41 versus 40. So, niraparib in patient with no residual disease after primary surgery, preliminary result with METO 40 study. I think we have already discussed that in median PFS, it was not reached, and the 12-month disease-free survival was around 85.3. So, PRIMA is a positive trial that has met its primary endpoint when evaluating niraparib monotherapy with first-line metastatic in patient with newly diagnosed ovarian cancer at high risk for recurrence after response to first-line platinum-based chemo. Niraparib demonstrate the sustained and durable effects in with both HR proficient, HR deficient intention to treat population, and a totality of efficacy and safety data across PRIMA, PRIME, and real-world evidence support the use of niraparib in all category of patient who responds to first-line platinum-based chemotherapy. So if we talk about the dosing, the dose is 100 mg. The method of administration is oral once daily. We have to swallow whole with or without food. Starting dose we have is 200 mg or 300 mg daily. The median terminal half-life is 36 hours, and there are very lesser drug interactions. So PARP inhibitors, the conclusion is PARP inhibitors maintenance therapy has shifted the paradigm of care in advanced ovarian cancer across biomarker subgroup. The personalized first-line maintenance treatment involves complex treatment decision-making utilizing multiple tools and factors beyond biomarkers, the disease characteristic, the chemotherapy response, and the personal preference. In addition to biomarker status and other factors, response to platinum-based chemotherapy is a key predictive factor because we all know deeper the response, the higher will be the maintenance effect of PARP inhibitors. And there are some third tools that is RECIST, KLM, and CRS on which we can see the response to chemotherapy. A total of efficacy and safety data across PRIMA, PRIME, and real-world evidence support the use of niraparib in HR deficient and HR proficient population who responds to first-line platinum-based chemotherapy. So again, wants to thank you to the organizer and Deepak Gupta sir for this opportunity, and thank you GSK for sharing the data. Yeah.
Thank you so much, sir, for concluding the session on time, before time, in fact. Thank you so much.
Yeah. Thank you. Thank you.
And now for the next session, I am again welcoming Dr. Jitendra Kumar Pailajani.
Can you share the slides? So thanks, Pooja again. Thanks, Dr. Deepak sir, for the invite. And this session is sponsored by Merck. And we will be discussing head and neck cancer, unresectable metastatic setting. Can you share the slide, please?
Out, please share the slide.
So this is regarding the response or survival for both in recurrent and metastatic head and neck cancer. So now we have various agents which we can use, like we have immunotherapy, we have anti-EGFR, immunotherapy, we have two agents, then we have oncolytic with low dose immunotherapy. So what should be sought in the patient benefit? What does patient want? Let us dive a little bit into the data, how we can better use these agents for our patients. Next slide. So Indian patients are different. We do all know because the data which West shares is different. Next slide. So what are the difference which we see? So basically, Western patients are oropharynx will be more is related to HPV in around 21% of the patient versus 7% in the Indian population. Oral cavity lips is the most common site in India. Stage of presentation is usually early in Western world because of awareness in the population. Indian patients are having aggressive disease, so locally advanced and recurrent disease are more. Disease aggression is usually more in the Indian subgroup of the patient. So we have means nutritional problems. We have performance status low because of the low economic status, tobacco chewing, alcohol chewing. All those things does play in the outcome of our patient. Next slide. So this is what means once in a month now we see. Although with the increased awareness, increased expertise available at various centers, so probably this is less, but still once in a month or twice in a month we do see the patient which has tumor rupturing out. There is a fungating growth. So 80% of Indian patients will have a high tumor burden and will be symptomatic, unable to open mouth. There will be porocutaneous fistula. Next slide. So with highly symptomatic cancers, patient expectation should be considered. And if you ask, so there's a data of TMS study that primary site was oral cavity, 141 patients were there. And the primary expectation of the patient was symptomatic relief alone or in combination with prolongation of life. Around 58% of the patient. Next slide. So this is what NCCN guideline recommends. It recommends if the patient is having recurrent, unresectable, or metastatic disease, probably pembrolizumab or platinum agent is category 1, first line, or if chemo CPS is more than one, pembrolizumab alone can be given. Other recommended regimen is cetuximab, platinum, and 5-FU, which is also a category 1 recommendation. Subsequent line, if not previously used, nivolumab can be given, or cetuximab can be given if not used earlier. Next slide. So coming to how to interpret PDL1. So we all know that PDL1 is a dicey marker, although we use it for our immune therapy decision making in head and neck, lung cancer, breast cancer, cervical cancer, but esophageal cancer. But how means we know it is dynamic, it is not consistent, it depends on the method what we use. So there are various things. So this data from Taiwan, which suggested that program TDL1 and tumor burden score can guide us that how to best treat the patient. So what is the tumor burden score? Basically, there is a set of uh, tumor burden, means they will see the burden of the tumor by imaging, and if it is more than 5.66, it is a high tumor burden. If it is less than 5.66, it is low tumor burden. So they classify two patients into low tumor burden and high tumor burden. So the survival was better in low tumor burden, obviously, uh, as well as PFS. Next slide. So this is tumor burden, which suggests that if there is high tumor burden disease, probably the survival is poor, the PFS is poor, and the disease is aggressive. Next slide. So coming to the clinical trials regarding overall response rate and median overall survival with cetuximab plus chemotherapy. So there are three trials which were along with carboplatin, cisplatin, or 5-FU. So they had a response rate of around 30 to 55%, which has median overall survival of around 10.1 months to 13.1 months. Now we have 5 studies which suggest that cetuximab, cisplatin, and taxane. So we can use with both the primary regimen, 5-FU based or Taxol based, and the response rate is around 40 to 60%, with a median survival of around 10 to 15 months. Next slide. So this is the real world evidence. So this is There are various retrospective data by Dr. Rangaraju, Dr. Bahel, Dr. Chandrakant from India, Dr. Tiwari, few Chinese data like Change 1, Change 2. So these data suggest that uh, overall response rate was around on the tune of 45 to 80% if you use cetuximab plus chemotherapy in Asian subgroup of patients. And overall survival is around 9.2 months to 15.1 months in these real world evidence. Next slide. So early response is key to symptom management, which in turn provides better outcomes. So overall response rate definitely, if the tumor shrinks, patient is able to pain reduces, patient is able to eat, patient is able to talk. So definitely health related quality of outcome improves in these patients. Next slide. So this is regarding the efficacy of Erbitux, which is means efficacy of Erbitux is persistent amongst all the CPS score, means whether it is low or high. On the contrary, if you use IO, probably as the CPS score increases, the efficacy ORR and OS improves with the CPS. So cetuximab gives us a streamlined survival as well as response. Next slide. So this coming to the data of CPS, how CPS we are classifying. So because some studies say if CPS more than 20 is better for IO. If it is less than that, probably we can use anti-HER2 therapy, anti-EGFR therapy. So here we can see that response rate and progression disease. So response rate for extreme is almost similar, irrespective of the CPS. On the contrary, if CPS more than 20, the response rate for pembrolizumab is around 23%. If it is less than 1, it is lesser than 5%. So if CPS is low, probably immunotherapy doesn't work in monotherapy. Next slide. So coming to the CPS more than 20 subgroup. So this is the keynote 48 data that almost response rate was double in CPS more than 20 arm if you used the uh, mm, extreme regimen. Next slide. So previous slide. So this is the overall survival benefit in overall population of patient subgroup in pembro chemotherapy arm of keynote 48. So here we can see that the difference in the survival was not clinically was not significant, and the events were almost similar in both the subgroup. At 12 months, it was 43.9 versus 46.9 in pembro chemo versus extreme. Next slide. Determining the role of various subsite in uh, of various chemotherapy combination in the oral cavity tumor, which is more common in India. So here we can see that extreme phase 3 trials suggest that in oral cavity, it favors the Erbitux plus chemotherapy arm. The median overall survival is around 11 months versus 4.4 months in the chemotherapy subgroup. So it benefited far better when you compare with the chemotherapy alone. In the real world example also, real world evidence also, oral cavity patients fare far better when Erbitux was used. In the change to phase 3 trial, also the response rate as well as the overall survival was uh, better when we have used Erbitux. An Indian study by Dr. Ankur Behel et al. Is overall survival was around 12.23 months, which was better than the chemotherapy. Slide. So platinum-based chemotherapy plus rituximab in head and neck cancer, this was published in NAGM. And in oral cavity, we can see that 11 months versus 4.4 months. The majority difference was derived from this subset of the patient. Next slide. So first line treatment with chemotherapy plus rituximab in the Chinese patient. This was a phase 3 Change 2 trial. And here also we can see that the overall survival benefit was almost double in oral cavity subgroup of the patient, which was then trending towards rituximab. Next slide. So this is the tumor site analysis of Dr. Ankur Bahl data, which was published from the Fortis Memorial Hospital, Gurgaon. So here we can see that if almost 64% patients were from the oral cavity, around 20% patients from larynx and 20% patients from oropharynx. And we can see that almost 68% patient in the oral cavity were metastatic, and around 60% patient of them were treated with cetuximab. So overall response was around 70%, uh, 70% in the oral cavity. Next slide. So here we can see that overall survival was more than double when cetuximab were added to chemotherapy, 5.8 months versus 12.23 months, and the overall response was 74%. Although in larynx and oropharynx the data was better, but it was not doubled. Next slide. So here also in the subset analysis, it was favoring in oral cavity for the cetuximab. Next slide. So how does these oral cavity cancers, right, present with high immunosuppressive cells that may affect the treatment response with immune checkpoint inhibitors? So there is an immune suppressive microenvironment because of increased IL-1 beta, IL-10, and TGF beta, which lead to immune suppression, and there will be increased IDO in the milieu, which leads to the T regulator cells activation. Next slide. So this is the outcome among patients with mucosal head and neck squamous cell cancer treated with checkpoint inhibitors. So here we can see in the oral cavity, HPV positive oropharynx and all the primary other sites. So overall survival from a retrospective data of 212 patients, 50% lesser survival in oral cavity patient when we compare to the HPV positive patient of oropharynx. So as we all know that HPV positive patients do fare better with immunotherapy and their overall outcome is better than the non-HPV positive patient. Next slide. So coming to the subgroup analysis of keynote 48, in pembrolizumab with or without chemotherapy in recurrent metastatic head and neck cancer, we can see that metastatic patient of oral cavity were around 90 and recovered 65 of 70. So in this also the recurrent patient did favor cetuximab chemotherapy for oral cavity. Next slide. So whether to sequence this drug and how sequencing will help. So that leads us to the mechanism of action of Erbitux. As we all know, it's a targeted therapy which target anti-EGFR site. So basically, Erbitux bind to the EGFR receptor. Then there will be internalization. The second thing is it's bind to the EGFR receptor, and on the place of internalization, it will lead to activation of NK cells, which leads to increase the PD-L1 expression. So there's a direct effect and indirect effect, which lead to basically activation of the immune milieu. Next slide. So how sequence is important. So here is the data of TP extreme that if you use TP extreme first line, the median overall survival is 14.5 months. If you add the second line immune checkpoint inhibitor, the median overall survival is 21.9 months. Similarly, with extreme also, the median overall survival is 13.54 months. And if you add an immune checkpoint inhibitor second line, the median overall survival is 19.4 months. With overall response rate at 12 weeks around 60%. Next slide. So this is a treatment sequence study which was done in China. So it was a retrospective observational study of 75 patients in which cetuximab cisplatin plus IVQ, 40 patients were taken. Pembrolizumab cisplatin plus IVQ first line was given. After that progression, second line patient was given. So the median overall survival was almost similar, 23 versus 22.8 months if you use. But the overall responses were better when you used cetuximab in the first line. Next slide. This is the Indian data from Kolkata by MV Chandrakant. So patient treated with paclitaxel, the overall response rate was the tune of 80%. The PFS was 7 months. And the patient progressed. The second line was nivolumab on 19 patients and OMCT in the 10 patients. Next slide. So in this subgroup of patients, the median overall survival if patient received the first line cetuximab followed by nivolumab, the median overall survival was 20.4 months, with the overall response rate of 37%. Next slide. So this is the
I
real world
request you
evidence
to
that
conclude this.
okay. So this is
Sir,
the Indian
request you
data
to
and
conclude the session in 1 minute.
just 2 minutes. So if you use the first line Erbitux followed by second line ICI nivolumab, the median overall survival is 20 per 4 months. Next slide. So you can see that if there is a bulky tumor with necrosis, rapidly growing tumor requiring rapid symptom relief, so probably in those cases, cetuximab is a better drug to go, irrespective of CPS. Next slide. Next slide. So coming to the conclusion, each patient with previous slide, each patient with recurrent metastatic head and neck cancer is unique. Treatment decision should be based on patient needs. Genetically and etiologically, Indian patients are different than the Western population. Factors like tumor size, symptoms, burden, pace of disease, biomarker status are important. For response or survival, cetuximab plus chemo provided consistent and deeper benefit response. Cetuximab plus chemotherapy followed by ICI given a good median overall survival of 20 to 24 months. The TP extreme subgroup analysis and RWE, cetuximab based regimen in first line therapy followed by immunotherapy in second line can lead to reaching of OS around 20 to 25 minutes. Thanks.
Thank you so much, Jiten sir. Now, the next session is sponsored by Intas. The session is presented by Dr. Mansi Ghosh. She is Doctor Consultant, Medical Oncology, BMC, HRC Jaipur. Over to you, ma'am.
Good evening. Good evening, all. Good evening. Thank you, organizer, for giving me the opportunity. And thanks a lot to Deepak Gupta, sir, for giving me the opportunity presenting tonight. And thanks to Intas for providing me the slides. Kindly share the slides. Today, I will be speaking on the evolving landscape of HER2-positive metastatic breast cancer. I will provide an provide an I will provide an overview of evolving treatment options for first-line treatment for HER2-positive metastatic breast cancer, and will be addressing some key questions like should all patients receive TDXD with along plus minus pertuzumab as first-line treatment, and with the evolving first-line systemic therapies, what's the role of maintenance HP along with the TKIs and CDKIs? Can we further personalize the systemic treatment? Next. Just give me some time. There is some technical glitch. This slide shows the evolving landscape of the various FDA approvals for the HER2 positive MBC. It all started in 1998 when monoclonal antibodies has been added to the chemotherapy and showed survival benefit. And the other approvals are like TKIs, various ADCs, and various combinations. Next slide, please. It all started in 1998 when monoclonal antibody has been added to chemotherapy, which showed a PFS benefit of about 7.4 months. Later in 2012, with the Cleopatra, the standard of care has become the combination of taxane, trastuzumab, and pertuzumab, with an overall response, overall survival benefit of about 16 months. At the 8-year follow-up, where about 37% patients are still alive, and with HP maintenance is still continued in 16% of the patient. Next. In DB09 2025, they compared TDXD plus pertuzumab along with THP. TDXD plus pertuzumab combination showed a survival benefit of about, the delta is about 14 months. It can become a practice-changing line of treatment and likely to become the new standard of care. Next. In Patina trial, along with the endocrine, those who have been upfront given THP protocol and has not shown progression has been randomized to maintenance therapy with HP along with palbociclib and endocrine therapy, and the other group has been randomized to placebo. It also showed a PFS benefit with the addition of targeted therapy to HP, and can be a practice changing treatment line in coming days. It showed a PFS benefit of about 14 months, and it also showed benefit. Next slide, please. I will be discussing the HER2 Climb 05 trial, a randomized double-blind phase 3 study of tucatinib versus placebo in combination with trastuzumab and pertuzumab maintenance therapy, HER2 positive metastatic breast cancer, which was presented by Dr. Hamilton et al. Next. In final overall survival analysis, the addition of tucatinib to the pre-treated HER2 positive MBC with or without brain metastasis showed the improvement in PFS as well as OS. The PFS benefit is about 19.2 months, and it also reduced the first progression as along with nuance in death by about 45%. Next slide. The eligibility criteria for this trial were centrally confirmed HER2 positive MBC with no progression after 4 to 8 months of THP. The patient included were had ECOG of 0 or 1 and no or asymptomatic brain metastasis on the screening MRI. They were randomized 1:1 to tucatinib with a dose of 300 milligram per oral BID along with HP maintenance plus minus endocrine therapy every 21-day cycle, and the other arm is randomized to placebo, which has also been given BID. The primary endpoints were PFS, and the secondary endpoints included OS, PFS, along with CNS PFS, safety and quality of life, and pharmacokinetics. Next. The PFS benefit with tucatinib arm was about 8.6 months. OS data is still immature. Endocrine therapy has been given to 45% of the patient. And in patient characteristic, about 69% patient had de novo MDC, 53% were hormone receptor positive, 12% patient presented with metastasis to brain. 35% were Asians and 19% were Hispanics. The grade 3 side effects were very less. The grade 3 side effects seen were diarrhea, nausea, and transaminitis. The diarrhea is about 6%, nausea was about 1% only. Next. The slide is showing the PFS by hormone receptor positivity along with the CNS PFS. In hormone receptor status, those who were with hormone receptor negative showed a PFS benefit of about 12 months, and those who were hormone negative showed a PFS benefit of about 6.9 months. And endocrine therapy has been permitted in this trial. About 50% of the patient, less than 50% patient received endocrine therapy. In CNS PFS, there is a numeric improvement has been seen in CNS PFS in patient with baseline brain metastasis. Next. This slide shows the comparison of various first-line trials in HER2 positive MBC, includes Cleopatra trial, DB09 trial, Patina trial, and HER-CLIMB trial. In Cleopatra trial, endocrine therapy was not permitted. In DB09, in TDXD arm, it was about 13% of the patient were permitted to take endocrine therapy, and in THP about 38% patient received the endocrine therapy. In Patina, where post-THP patient were subjected to maintenance therapy with HP along with palbociclib or placebo, 100% of the patient received endocrine therapy. In HER-CLIMB 2005 trial, post-THP maintenance HP was added along with tucatinib, and 45% patient was subjected to endocrine therapy. The maximum PFS has been seen in Patina trial, which is about 44.3 3 months, and the OS data is still immature in most of the trials. The OS benefit has only been shown in Cleopatra trial, which is about 56 months. The direct comparison of the various trials is not possible because where the studies were conducted, study population, as well as prior and concomitant systemic treatments received. Cleopatra and DB09 measured the PFS from time of randomization prior to induction THP, whereas in Patina and Herclimb 05, randomization was after completing THP, excluding the patient who progressed on this regimen. Next. For further personalizing the first-line treatment, whether should we consider the first-line TXD plus pertuzumab versus THP, the various benefits which has been shown in first-line TDXD plus pertuzumab is there has shown an increased PFS with more CRs cure rates, which can lead to more cure rates. 20 to 30% of the patient had not received second-line treatment. Maybe this is for, therefore the exposure is potentially now or never, and treatment, and it has been found that TDXD plus P also treated brain metastasis and prevented further development of new brain metastasis. What are the cons or disadvantages for TDXD? Most of the patient, they had to prolong side effects, chemotherapy-like side effects. About 2.5 years, they have to face the chemotherapy-like side effects. ILD is the most fatal complication of TDXD. Even some patients showed cure of THP regime, and HP maintenance also had a excellent quality of life. So phase 2 stop HER2 trial is evaluating if patient with sustained radiological complete response can safely continue maintenance HER2 targeted therapy or not. Next. And the other question is, how long should we give TDXD plus pertuzumab? It has been seen the maximum response is achieved within the first 3 months of therapy. The method is the trial, which is assessing the role of 6 months of TDXD plus pertuzumab, but it's a small non-randomized study. And for further guidelines, we will need further large randomized trials. So first we can start with TDXD induction followed by HP maintenance. Duration for TDXD is still not known, but 6 months could be considered. And does everyone need the TDXD plus pertuzumab combination? TDXD DB09 has a randomized patient to TDXD monotherapy as well, but the results are awaited. Next. And other clinico-pathological factors which can further help us to personalize the first-line treatment of HER2 positive MBCs are visceral metastasis, PIK3 mutation, brain metastasis, quick relapse after first line of treatment, and HER2 heterogeneity. These are the high-risk factors. These patients can be subjected to TDXD plus pertuzumab treatment, and the other low-risk treatment, like a low-risk disease like de novo MBC, longer DFI with non-visceral disease, patient with strong HER2 positivity and oligometastatic disease can be subjected to THP protocol. The takeaway is like lower risk disease can be started with THP, followed by HP maintenance along with palbociclib for hormone receptor positive and HP maintenance along with tucatinib hormone receptor negative disease. Next. Other emerging approaches to help us with the selecting of first-line treatment in HER2 positive MBCs are genomics. It has been found that PIK3 mutation causes an aggressive disease. It's better to start with TDXD. Like ctDNA, if there is a rapid drop after chemotherapy or other therapy, we can de-escalate the treatment. HER2 DX4 is also very much helpful for personalizing the treatment. Patient with a high ERB2 score has been found to have longer PFS. Other systemic biomarkers along with radio mix, that is radiological imaging, if there is a good response to treatment, we can de-escalate the treatment, and we should wait for the various clinical trials with novel drugs which are continuing. They may also help us to personalize the treatment with the results. Next. The summary of HER2CLIMB-05 is the second trial showing efficacy of adding targeted therapy to HP maintenance with the PFS of about, delta of PFS is about 6.8 months. It showed a 36% reduction in the risk of disease progression or death. It also showed a numeric CNS PFS improvement with tucatinib. Next. For optimizing the systemic therapy, I will answer the question which I has asked earlier. Should all the patient receive TDXD plus pertuzumab? It depends upon the heterogeneity of disease, patient factor, and the patient comorbidities along the preferences, along the patient preferences. The next question is, with the evolving systemic therapy, what's the role of maintenance HP? If after first line THP, there is no progression of disease, we can consider palbociclib as per Patina trial and tucatinib as per the HER2CLIMB-05 trial for maintenance therapy along with HP maintenance. Result from other maintenance trial like SURGE and PIC-I are still awaited. It can also impact our treatment. Post-TDA induction trials with HP along with targeted ET therapy and targeted therapy can also help in personalizing the systemic therapy. While we can further personalize systemic therapy, these are the biomarkers which can help us to personalize the systemic therapy in selecting the regimens like TDXD versus THP or cytotoxic chemotherapy, and can help with defining the treatment duration, de-escalation, and discontinuation. Next. The top takeaways are, for first-line HER2 positive MBCs are, we have two options to add to HP maintenance therapy. In hormone receptor negative treatment, we can add tucatinib to the HP maintenance. For hormone receptor positive, we have two options, either palbociclib or tucatinib, but palbociclib is preferred. Adding ET to HP is critical as it showed a PFS improvement. And for first-line treatment choices, we have two options like TDXD plus pertuzumab and THP. TDXD plus pertuzumab can be preferred in patients with brain metastasis along with leptomeningeal diseases, visceral mets, and heterogeneous HER2 positivity. In patients with oligometastatic disease, de novo metastatic disease, and non-visceral mets with strong HER2 positivity, we should consider THP, and we can de-escalate and escalate the treatment with the help of various genomics, radiomics, and biology of treatment, biology of the tumor as such. We are moving towards a brighter future for our patient. And thanks a lot for giving me the opportunity to present the slides. Thank you. Thank you, organizer, and thank you, Deepak sir.
Thank you so much, Mansi ma'am. Now our next session is with Dr. Ankur Nandan Varshne. The session is sponsored by Zydus. Dr. Ankur is Senior Consultant, Medical Oncology, Medanta Hospital. Over to you, sir.
Hello. Hi, good evening. And the most important question, are my slides visible to all?
No.
Sir, abhi nahi.
Right now they are visible?
Yes, sir.
And second most important, are they moving to you?
Yes, sir.
Okay, so thank you, Dr. Deepak Gupta, for inviting me to this esteemed meeting of yours. And I know I'm the last person standing between you and dinner, so I won't take much time. And I start with role of nivolumab in non-small cell lung cancer. And why we are discussing is this because of the presence of a biosimilar, this Tishta, which have been launched. And this have been a long journey starting from clone development to 2015 to first approval in 2020, then getting a phase 3 clinical trial from 2020 to 2024. And luckily, I was one of the members at the initial site, and then getting DGCI approval and fighting a legal battle to a launch of this in 2026. And why this is a game-changing event? Because of the financial estimates, because in India, immunotherapy was still considered out of reach to a majority of our population. And this molecule has it has made availability to a middle-class Indian family. So with this, we are going to have many patients and they are going to get advantage of this. So what does Tishtha, a biosimilar nivolumab contains? It contains a glycosylated human monoclonal antibody, and this is expressed in genetically engineered CHO-like cells and developed with the same pharmaceutical composition as the innovator brand. So it's available in 40 mg and 100 mg as the standard innovator brand. And coming to the most important part in the non-small cell lung cancer, so how nivolumab is FDA approved in lung cancer? The very first thing, it is approved in neoadjuvant treatment of resectable non-small cell lung cancer in combination with platinum doublet chemotherapy if tumor size is more than 4 centimeter or node is positive, especially for the patient population who is PD-L1 positive. And coming to the metastatic non-small cell lung cancer, and any non-small cell lung cancer which is metastatic and target negative, then immunotherapy takes the center stage. So nivolumab is combining with ipilimumab, is approved as the first line for treatment in patients with NSCLC who express PD-L1 more than 1% with no EGFR or ALK tumor genetic aberrations. Nivolumab is also approved in combination with ipilimumab with 2 cycles of platinum doublet chemotherapy as shown in 9LA study. And nivolumab is approved as monotherapy for treatment of adult patients with metastatic non-small cell lung cancer who has progressed after platinum-based chemotherapy in patients who harbor EGFR or ALK genomic tumor. It can be offered to those patients after the disease has progressed post tyrosine kinase inhibitor therapy. So scientific basis, starting in the resectable non-metastatic lung cancer, the main why the combination of neoadjuvant immunotherapy is approved. The concept is to target the presence of microscopic METs. And with the neoadjuvant schedule, we have option of combining chemoimmunotherapy. And this neoadjuvant immuno-oncology prime the immune system more effectively prior to surgical resection because of the advantage is there are presence of abundant tumor neoantigens in the blood at the time. And these can be targeted with this and leading to reduction in the size of the tumor and post-surgery. Adjuvant immunotherapy has a role to reconstitute or boost our immune system following surgery-induced immunosuppression, and this can lead to further disease control. So how early intervention can help? We know postoperative recurrence remained high, especially in patients who are having lymph node positive. And this is because approximately 6 in 10 patients with early stage non-small lung cancer has a chance of recurrence. Early treatment with neoadjuvant chemoimmunotherapy had shown in various studies to show a greater PCR benefit as well as EFS benefit. And the most important thing is the safety concern. With the addition of nivolumab, it does not lead to increase in the grade 3 or 4 adverse events. So why we should go? Because we have a surplus data. It has been showed to increase in the PAT-CR rate. PAT-CR rate has increased with the introduce of immunotherapy from 2% to 24%. EFS benefit has increased from 18.4 months to 43 months. We see its data is not actually doubling or tripling, it's going 10 times. And the addition of nivolumab to chemotherapy has not shown any increase in the side effect adverse event. And the advantage with nivolumab is this is a flexible dosing schedule. 360 mg can be administered every 3 weeks for a total of 3 cycles over the duration of therapy. So neoadjuvant immuno-oncology harnesses the power of immune system to enable a strong anti-cancer response in early stage therapy, and currently all international guidelines recommend the use of chemoimmunotherapy for eligible patients with resectable lung cancer who are being planned for surgical resection. And we start this scientific basis was provided by Checkmate 816. This was a phase 3 trial where patients with the newly diagnosed resectable lung cancer from stage 1B to 3A with no prior sensitizing EGFR or ALK were randomized either to receive nivolumab with chemotherapy every 3 weeks or plain chemotherapy. After 3 cycles, these patients underwent surgery within 6 weeks of therapy and followed by optional adjuvant treatment, whatever the CTRT was indicated. The primary endpoint of this study was PAT-CR and EFS. Secondary endpoint was OS. So histologically confirmed stage 1 to 3 NSCLC. And the most important thing which we have to focus is the resectable disease. In exclusion, we have to follow that EGFR mutation, LL mutation should be negative. So these are the baseline characteristics. If we look at this criteria, approximately 43% patients were PDL1 less than 1%, means negative, and approximately 49% patients were having PDL1 positivity. Out of them, 20% patients have PDL more than 50%. Prior to this, both cisplatin and carboplatin was used in chemotherapy arm. So what we found is the sudden jump in the PATH CR from 2% to 24%. So it's more than 10 times. And if we say that the PATH line CR with the baseline staging, so as early stage was involved, PATH CR significant percentage was increased. So we do not say that immunotherapy is reserved for the advanced disease. Even in the early stage, we are getting a significant benefit. Coming to the depth of tumor regression, yes, it was more pronounced. If we can see these waterfall plots, we can say that in patients with the nivo with chemo, the depth of pathological regression was quite significant. Coming to the EFS, which we are targeting, so the use of chemotherapy, the median EFS benefit was only 18.4 months. It jumps to more than 2 times. With the nivo with chemo, it was 43.8 months. At the end of 4 years, if we see, the 49% patients in the chemoimmuno arms were event-free out of 38% in the chemotherapy arm. And if we see the separation of this continue to prolong further. So coming to the 5-year OS data, it has shown that 5-year OS rates were 65% for the combination compared with 55% at the chemotherapy arm. And this benefit of overall survival was consistent across all stages as well as PDL1, irrespective of PDL1 status. So this is the curves which have shown that any type of surgery, either minimally invasive or thoracotomy, lobectomy, pneumectomy, or any other, we see a better benefit of introduction of immunotherapy to the chemotherapy arm. And if we follow the ctDNA clearance, then yes, ctDNA was rapidly cleared with the introduction of immunotherapy, and this leads to an increased overall survival. Coming to the most important thing, the safety summary. So if we see the all-cause adverse event, this was 92% in the immunochemo arm, it was 97% in the chemo arms. And if we see grade 3 or 4 adverse event, then it was even more in the chemotherapy arms. Majority of adverse events were related to the chemotherapy. And immunotherapy adverse related event, we only see pneumonitis grade 1 in 2 patients. Coming to one more study, which is Checkmate 77T study. This includes patients, again a phase 3 trial, includes patient with untreated stage 2A to 3B patients, NSCLC, and patients were randomized to nivolumab 360 with chemotherapy or placebo. Now, after surgery, patients were offered nivolumab as an adjuvant therapy. Was difference from the previous study? They only give 3 cycles of new adjuvant therapy, and now we are going for a perioperative regime. So after initial treatment with nivolumab, these patients were offered nivolumab maintenance 480 mg every 4 weekly for a year. The primary endpoint was again EFS. So these are the completed treatment and surgical outcomes. We see there was an increase in R0 resections. And if we see the EFS data and overall survival summary, we see a numerical advantage of using perioperative nivolumab. 18-month EFS was 70% versus 50%. So in a stage 2, it was 78% versus 73%. On in stage 3, it was 71% versus 52%. So we are getting a EFS benefit with the addition of nivolumab as an adjuvant therapy. Now, more important thing, if we go with the PDL1 expression, in patient population who have PDL1 less than 1, 12-month EFS rates were 69% versus 67%. In the PDL positive patient population, it was a huge jump from 76% to 54%. And if we go with the patient population where PDL1 expression was more than 50%, we see with the nivo chemo arm, it was not recordable till now. So as high, the simple concept, as high as the PDL1, there is a more benefit of adjuvant protocol. Comparing to the pathological responses initially achieved through neoadjuvant protocol continue to be benefited in the patients. And then the patients who didn't achieve PET-CR still did better with the use of adjuvant nivolumab. So what this study concluded, neoadjuvant nivolumab plus chemotherapy followed by surgery and adjuvant nivolumab was associated with a significant and clinically meaningful improvement in PFS versus neoadjuvant chemotherapy. PET-CR rates again jumped from 4.7 to 25%. And there was EFS benefit with perioperative nivolumab located in patients with PET-CR even after neoadjuvant therapy, in patients eligible for adjuvant therapy regardless of PET-CR status, and in patients even who were unable to receive adjuvant therapy had a slight better role with the limited doses of nivolumab given. So the outcome supports the use of perioperative nivolumab as a potential new treatment. Coming to checkmate 9LA. So from moving now from stage 3 to stage 4, we have in checkmate 9LA phase 3 data for patients with stage 4 recurrent NSCLC without any EGFR or ALK mutations. These patients were randomized to receive either nivolumab 360 mg 3 weekly with ipilimumab 1 mg per kg every 6 weekly, along with chemotherapy for only 2 cycles, plus chemotherapy every 3 weekly. And these patients were continued until progressive disease or unacceptable toxicity. The primary endpoint of this study was overall survival. So what we got is the 4-year updates with the overall survival. The median OS in all patients includes 15.8 months with the Nivo AP with chemo arm, while chemo arm it was only 11 months. If we see patient outcomes in the PDL positive patient population, it was 58.8 months versus 10.9 months. And the most important thing why this study surprised was the patient population where PDL1 was negative. The advent of this combination in PDL negative patient population, median OS was 17.7 months, while in the chemotherapy arm it was 9.8 months, near about doubling of this. So magnitude of OS was benefit was greater irrespective of the PDL1 population, and this is one of the practice changing regime where limited chemotherapy was given in the patients with metastatic lung cancers. So this is the persistent of overall response rates as duration of response, which are far better in the immunotherapy cohort as compared to the chemotherapy cohort. And this is so patient who discontinued because of side adverse event, even the median OS was better than the patient who received chemotherapy. It was 27.5 months. And this is better irrespective of the histology of the tumor. So coming to the 6-year update with overall response rate. So 6-year overall response rate includes 38% versus 25%, duration of response 19 versus 0, PFS 9 versus 3, and OS 16 versus 10. So we are getting that this combination is offering an advantage in overall all patient populations. So the study concluded that nivolumab with ipilimumab with chemotherapy continued to sustain an overall survival benefit irrespective of the PDL1 and histology. The responses are long-lasting with 19% of responders maintaining response at 6 years. There's a PFS benefit, as well as all these benefits are maintained across in PDL positive as well as PDL negative patient population. And an important key takeaway, especially if the patients are having KRAS, STK11, KEAP1, TP53. So these are the genes where immunotherapy is considered resistance. But this patient population was majorly benefited with this combination cohort. So coming to now checkmate 227 study design. This is stage 4 NSCLC patients.
Yeah, Dr. Ankur sir, sorry to interrupt, but you have a minute to conclude, sir.
Okay, so this study is known to us, and I will just this is a stage 4 where initial combination of NSCLC in this patient's single agent nivolumab was offered, and patient is still reported survival outcomes in the all the patient population. So right now we are having Tishta, which is a biosimilar, and we can offer this as a cost-effective dose. Thank you.
Thank you, Dr. Ankur, for such a wonderful presentation. I think now we are coming to the conclusion of the day's webinar. Can we have Dr. Deepak Gupta, sir? Sir,
Yes,
once
I
again,
am
good
here.
evening, Dr. Deepak, sir. If you can just summarize the whole discussion for today, and then we will invite everyone for tomorrow. Over to you, sir.
So today it was very exhaustive discussion on breast and gynec cancer, basically endometrial ovarian cancer. We learned about new abstracts, practice-changing abstracts from ESTO 2026 by Dr. Amit. And we had a brainstorming on endometrial cancer by Dr. Ankit Agarwal and role of immunotherapies in first-line treatment of endometrial cancer. Overall, I think it was a very good discussion today, and hope we could learn something which we can incorporate into our clinical practice now onwards. And thank you all the faculties for sparing your valuable time today, and thank you your tech team for smooth flow of the meeting and concluding in time. Thank you everyone, and have a good night.
So thank you, Dr. Deepak. On behalf of my colleagues, Daud and Pooja, it's a time to say thank you and goodbye. And we meet again tomorrow sharp at 7 p.m. for tomorrow's discussion. So once again, thank you so much, everyone, for active participation. Uh, Technical team, can we now close the discussion, please? Thank
Yes,
you.
sir.
Thank you.
Thank you.